We are live now, sir.
Yeah.
Janardhan, we should start. Neeraj, please call the moderators and get the session going.
So, very good afternoon. I welcome all the presenters, the audience, and as well as moderators for this free paper session. I, Dr. Ramchandra from Bangalore, along with Dr. Shal Wali, will be moderating the session. So, the first topic will go directly. Dr. Sri Vijayanand will be presenting a talk on Proteomic evidence on etiopathogenesis of adolescent idiopathic scoliosis.
Respected seniors, colleagues, and my dear friends, good afternoon, everybody. I'll be presenting my topic on proteomic evidences on etiopathogenesis of adolescent idiopathic scoliosis. Adolescent idiopathic scoliosis is the most common spinal deformity, the etiopathogenesis of which has been proved from various angles of genetic, neurological dysfunction, biomechanical, hormonal, and developmental disturbances. Various hypotheses and theories exist. However, no direct cause-effect relationship has been established till now. AAS has a strong genetic basis with increased incidence noted among first-degree relatives and higher concordance rate in monozygotic twins in comparison to dizygotic twins. The genetic association studies have identified numerous genes. However, they were not replicable in different populations. In AAS, there are many unanswered questions like what initiates a deformity, what causes progression, why only few progress, and whether the changes noted are primary or secondary to the deformity. With this in background, we did a proteomic analysis of scoliotic disc to understand the role of intervertebral disc in AAS, to evaluate the possible clues and links on etiopathogenesis of AAS. The study was conducted in Ganga Hospital and Ganga Research Center, Coimbatore, and was funded by Gaurav and ASSC Research Grant. Materials and methods. 8 scoliotic discs from 3 patients who underwent anterior deformity correction for AAS were compared with 8 normal discs from brain-dead voluntary organ donors. The protein analysis was performed using liquid chromatography and tandem mass spectrometry, and bioinformatics was used to compare, identify, and characterize the constitution of scoliotic disc. The results showed that the normal disc had a total of 1,094 proteins, of which 410 were unique. The scoliotic disc had a total of 1,585 proteins, of which 901 were unique to scoliotic disc and 684 were shared between the two groups. Among the upregulated proteins in this group, the significant ones were the collagen, maternine, osteonectin, procollagen C proteinase enhancer, neurotropin, calcium binding proteins, and Wnt proteins. And among the downregulated proteins in the scoliosis group, the growth differentiation factors, neuroreglin, cochlein, cartilage oligometrics protein, and fissure-related protein were the significant ones. Among the pathways, Wnt5A pathway and downregulation of TGF-beta receptor signaling were the significant pathways found in the scoliosis group. Coming on to the discussion. Why study disc? Studies have noted changes in the ultrastructure of scoliotic disc, believed to contribute to the increased flexibility of the spine. The notochord with its membranous sheath is the earliest form of spinal cord known, and embryologically nucleus pulposus are remnants of notochord, and studying it could provide clues on the genetic and developmental abnormality. The changes in ultrastructure of the disc were noted where matrilin, a protein secreted by chondrocytes, has an important role in organization of chondrocyte into distinct zones of growth plate, and its disturbance could lead to scoliosis. Procollagen C proteinase enhancer is an important determinant of bone mechanical properties, geometry, and of collagen fibril morphology, and both were upregulated in SD group. Disturbance in posterior equilibrium is a known theory in AIS. Neurotropin, a protein strongly associated with proprioceptive feedback mechanism to adjust postural control, were upregulated in SD, and promoter polymorphism of neurotropin has been associated with curve severity and trace responsiveness in another study. Cochlein, a protein abundant in inner ear and related to mechanosensation, was found downregulated in scoliosis group. Among the pathways, Wnt signaling controls the self-aid decisions and tissue patterning during the early embryonic and later development, and its mutation has been linked to human birth defects and cancer. Recent studies have confirmed it to be a major pathway in AAS pathogenesis. Our scoliosis group had an upregulated Wnt proteins and pathway and downregulated Brazil-related protein and inhibitor of Wnt. To conclude, I would say that our study confirmed the presence of many proteins documented in genetic studies. We identified many new proteins involved in embryogenesis, bone cartilage growth, calcium binding proteins, mechanosensation, and Wnt signaling with a potential role in etiopathogenesis of AAS. We identified few pathways of significance also. The limitation being small sample size, no comparison of concave versus convex side done. Thank you.
We'll straight away go to the next topic and we'll have a discussion at the end of 5 papers. I call upon Nishant Mehta for his study on predictors of operative duration in posterior AS surgeries.
Good morning and greetings from AIIMS New Delhi. I'll be presenting our research on predictors of operative duration in posterior spinal fusion for adolescent idiopathic scoliosis. Accurate prediction of operative duration is necessary for efficient OR scheduling, minimizing surgical cancellations, shortening surgical wait lists, better risk stratification, and more effective preoperative counseling. In addition, prolonged operative duration has also been found to correlate with negative patient outcomes. Surgeons' estimates of surgical duration are notoriously unreliable, especially in a lengthy surgical procedure like posterior spinal fusion for AIS. The recent COVID-19 pandemic has thrown surgical services across the globe into disarray, with all non-essential elective surgery being cancelled in most healthcare systems. This has created a huge backlog of patients planned for surgery. The post-pandemic phase will require effective delivery of surgical care, which means that we need to ensure more optimal utilization of OR time. The objective of this study was to identify the various patient-specific, procedure-specific, and surgeon-specific variables which influence the operative duration in surgery for AIS and determine its impact on early post-operative outcomes. This was a retrospective cohort study conducted at a single center and recruited 130 AIS patients who underwent posterior spinal fusion. Operative duration was the primary outcome measure. The secondary outcome measures were the length of hospital stay, the need for perioperative blood transfusion, the rate of surgical site infection, the need for postoperative ICU stay, and the rate of early postoperative complications. Hospital records of 130 AIS patients who underwent posterior spinal fusion were retrospectively reviewed. Data regarding patient-specific, procedure-specific, and surgeon-specific variables, a total of 20 such variables were documented and analyzed and were fed into a multivariate regression model which was used to identify independent predictors of operative duration in these cases. Furthermore, the association between operative duration and selected early postoperative outcome measures was determined. As you can see from our baseline statistics, the mean operative duration per patient was roughly around 4 hours. Significant positive correlation was found between operative duration and severity of curve, axial rotation of the apical vertebra, number of fused levels, the number of screws inserted, and extension of the construct to pelvis. Significant negative correlation was found between operative duration and flexibility of the major structural curve and experience of the chief surgeon. In determining the best multivariate regression model, we found that 5 factors made it as a part of the model, which included the experience of the chief surgeon, the Cobb angle of the major structural curve, the number of screws inserted, the coronal deformity angular ratio, and the extension of the construct to the pelvis. Taken together, this model accounted for 41% of the variability in operative duration, with the strongest predictors being the experience of the chief surgeon and the Cobb angle of the major structural curve. In addition, a significant positive correlation of operative duration was found with estimated blood loss, the length of hospital stay, and the need for perioperative blood transfusion. The small sample size, retrospective study design, and the limited availability of information from the hospital records were the main limitations of the study. The ability to correctly estimate the operative duration will help in risk stratification, guide resource allocation, and allow for better preoperative counseling and better planning of operating room schedules. To conclude, a set of variables which predict the variability in operative duration during posterior spinal fusion for AIS was identified in our setup, with the experience of the chief surgeon and the severity of the curve being the strongest predictors in our study. I thank you for your attention.
Yeah, thanks for the paper. I call upon Dr. Mohammed Anwarul Islam for his presentation on scoliosis the axial translation technique.
Respected moderators and my dear friends, spine surgeons from India and different parts of world. I am Professor Dr. M.D. Anurul Islam from Bangladesh. My topic is axial translational technique using pedicular fixation in managing adolescent idiopathic scoliosis. Provides an effective method of correction. This is the introduction introduced by the Hippocrates, Alfred St. Jr., Paul Harrington, and Heath. This is the history of Bangabandhu Sheikh Mujib Medical University. It is named after the name of our father of nation, Bangabandhu Sheikh Mujibur Rahman. And it's a postgraduate institute where academic activities and research activities is daily going on. Scoliosis has a triplanar deformity, sagittal, coronal, and transverse plane deformity. Classification, there are general classification, non-structural and structural scoliosis. Non-structural has different types, structural also have different types. Idiopathic scoliosis is our concern. It is most common type and absence of any known etiology. There are clinical findings of scoliosis. Mostly the patient presents with deformity. Some patients present with neurological involvement and respiratory system and heart involvement. This is the test which differentiates the structural from non-structural scoliosis. There are several X-ray landmarks. You know, Cope's angle is most important and it is our concern for correction. And more pedicle method for rotation also important. Riser signs for maturation, it is also important for treatment purposes. There are several classifications, you know, King's classifications and Lanke's classifications. Among them are important for correction purposes. Treatment can be conservative and can be operative. Regarding operative treatment, there are several surgical approaches, anterior, posterior, and combined approach. Among them, axial translational technique is our today's concern. I have some case illustrations. Among them, one is illustrated here. Miss Afroja of 14 years presented to me with the deformity and Cope's angle was 75 degrees. This is the preoperative X-ray, photographs, and CT scan. Preoperative MRI sagittal, axial, and CT chest as well. Preoperative incision, peroperative incision, dissection, instrumentation, and closure. Postoperative Cope's angle is now only 20 degrees. And X-ray AP view, lateral view, and the photograph, postoperative states of photograph of the back. Methodology, study design, retrospective study from January 2008 to December 2020, total number 30%, averages was 14.24. And there are some inclusion criteria, Cope's angle more than 40 degrees but less than 90 degrees, significant systolic deformities. Results is the C that for proximal thoracic curve, improvement is 32.31%, and for the main thoracic curve, 62.06%, and for lower thoracic curve, 50.65%. Discussion, you just already know that the achievement of correction, and it is compared to the others, Grendel et al. And Mushaik et al. And Islam et al. The study's correction is similar. Conclusion, axial translation technique with pedicle screw and rod construct through posterior approach is a standard option to achieve good clinical and radiological outcome for patients of adolescent idiopathic scoliosis. Thank you everybody for patience.
Yeah, thank you for the excellent presentation, sir. I call upon Dr. Naveen for his spondylosis repair technique.
Good afternoon, everyone. I'm Dr. Naveen Pandit and I'm a fellow at the National University Hospital, Singapore. Our study was to find out whether there is a place for the surgical repair of the parts in adults in the spondylosis and the grade 1 spondylosis. As you all know, it's a fairly common condition with 6% incidence in the adulthood, with the low back pain being the common symptom. The common resorted treatment is the conservative, to which the most of patients respond. However, those patients where the conservative treatment fails for more than 6 months, and or if there is a progressive back pain, the surgical treatment is offered. The most common offered surgical treatment for them in adults is the fusion, because it's a more predictable way, and the Participate is the less explored treatment method in the adults because of the associated degeneration and the less favorable results in the literature. To summarize all the available literature, we did this systematic review and to find the answer whether there is a place for the Participate in adults. The search was conducted in June 2020 using the PubMed and Scopus and Web of Science using these search strings. And the inclusion was adult patients more than 80 years, where the standard Participate technique was done in the license analysis. The exclusion was those where the non-standard Participate technique was used with congenital degenerative or with canal stenosis. This shows the study design. When we searched, total of 5,813 articles were found, which after the reading the abstracts were reduced to 111, and after the careful reading the full text, total of 47 articles were available for review. So seeing the result, 93% of these patients were the young adults in the 18 to 35 years of age. The most common level involved whatever was the L5 followed by L4. The spondylosis was the primary diagnosis, and most of them with 14% having the grade 1 spondylosis. The pulse infiltration was the most commonly resorted test to confirm the source of pain, and the negative probability discography was used in 8 patients. Bilateral Participate defect was found in 324 patients and 11 in unilateral. Coming to the techniques used, all the techniques that are available were used for the Participate, like the bugs, scores, Marshall, pedicle screw. However, the most common method was used. Studies were the bugs in the 17 studies, 331 patients. If we see the minimally invasive, the bugs was the most commonly method resort for the invasive in the 10 studies. The time taken in the open surgery was fairly same in all of them. However, in minimally invasive, less time and blood loss was found. Coming to the outcomes, the successful Participate was using techniques found in 79 to 100% of the patients, with a positive long-term outcome in more than 80% of the patients. The overall union rate using this Participate in adults was about 83 to 73%, and fusion rate using the X-ray and the CT in the follow-up was 78 to 68%. It was found in the recent study, if the BMP was used, they found that 100% of the fusion rate. To return to the sports activity, those who underwent the Participate found in 80 to 90% of the patients in most of the techniques. Coming to the complication, the overall complication was about 11.9, with the implant loosening being 3.4% in most of the cases, and it was fairly common, fairly same for all the techniques. So based on this, we found that the age group 18-5 is an ideal age group for Participate. Those where we have ruled that the disc as a source of pain, and there are chances of highly successful results. Based on this, we propose criteria: age 18 to 45, mild degeneration, positive infiltration test, and normal discography. And on all these, we propose this treatment algorithm. Thank you for your time.
Yeah, thanks for presenting, Dr. Naveen. I call upon Dr. Munjal Shah as anabolic therapy, a payload option for resurgery in osteoporotic spine.
Good afternoon, everyone. Myself, Dr. Munjal Shah, presenting my free paper under mentorship of Dr. Abhay Nene. So this is a 71-year male with a recently done spine surgery presented to us with significant instability, back pain, and ulcer over the site where screw was backing out. Another female, 68-year female, had acute OVCF treated outside with vertebroplasty, presented to us with significant instability, pain, and she was developing PJK. Another lady with acute fracture post-surgery had significant back pain presented to us. So who spoiled all these cases? Let's go through this. Osteoporosis is a significant risk factor for a revision spine surgery. It can ruin a well-done primary surgery as seen before in these slides. We have studied surgical patterns in osteoporotic vertebral compression fractures. We have burned our fingers by doing only vertebroplasty and not treating osteoporosis. So more complications are seen as more and more elderly are operated, like screw backing out, cage displacements, rod breakage, screw cutouts. Most of them will require surgical intervention. To mitigate this, various attempts have been made in the recent past, like fenestration screws, HA-coated screws, cortical screws, variable pitch screws. But all these surgeries of revision are associated with higher morbidity and mortality in osteoporotic individuals, and additionally, the cost of such surgery is higher than the primary surgeries. The role of injection teriparatide is now very well known in acute OVCF, and it has practically replaced percutaneous vertebroplasties. And role of weekly teriparatide for osseous union is now studied and published in JBJS. Role of injection teriparatide in patients operated for osteoporotic spine with implant complications is not evaluated. We studied this as a retrospective study with 10 consecutive patients, 5 males and females. Average age was 65.5. Inclusion criteria include previously operated patient, osteoporotic individuals proven on DEXA, sedentary lifestyle, have not taken any treatment for osteoporosis, no focal neurology, advised revision surgery but were reluctant, fulfilled eligibility criteria for injection teriparatide. Excluded were focal or generalized infection, history of any tumor with bone involvement, previous spine surgery without implants. According to these criteria, 4 patients were lumbar fusion, 3 had dorsal lumbar fusion, and 3 had lumbosacral fusion. All patients' DEXA was below -3 and were not treated previously. Daily injections were started. They were followed up every 3 monthly and in emergency if they developed neurological deficit. Outcomes were taken measuring VAS, MODI, and implant position. As there was no classification, we extrapolated by using our old study on TB spine and classified it as excellent, good, fair, and poor. VAS and MODI scores significantly improved at 3 months and remained to be so at 18 to 24 months after starting treatment. Average duration was 19.4 months. Average follow-up post-completion is 16.2 months. 3 had excellent, 4 had good, 2 had fair, and 1 had poor outcome. None of them developed deficit, and 1 patient underwent surgery who had poor outcome. At the start of the talk, we had shown 1 lady with PJK and instability pain. She remained to be so post-completion. Another guy with this had X-ray was showing that the implant position remained same, and he was well clinically as well as after starting treatment of taking treatment of 18 months of teriparatide. Another lady who was shown had fracture and she improved significantly as her fracture healed. Osteoporosis is essentially a medical disease and surgery attempts to treat the complication arising from the disease process. So we recommend that the spectrum of the injection teriparatide can be widened in osteoporotic individuals with impending failure with no focal neurology. Injection teriparatide can be considered as one of the chief armamentarium to avoid revision spine surgery in them. So limitation was a small sample size and it cannot be generalized in all patients which are mechanically failing implant related issue arise. So we should all age gracefully. Thank you all for your patience.
Yeah, I think we can have a halt here and we'll have some small discussion of these 5 papers. Any questions from any other people? Or I'll go ahead. Dr. Sri Vijayanand. So, yeah, this is regarding what made you to think to go ahead and doing proteomic analysis of scoliotic disc when other people are also doing on bone mesenchymal cells. Some people did it on even. What is the special thing which you thought scoliotic disc could be at?
Yes, Sam. Nice to see you. So there have been plenty of studies on genetics exploring the etiopathogenesis of AS. However, there have been very, very little studies on proteomics. And disc part has been occasionally studied, and there are very few studies. I could even single out the studies that have actually studied the discs. As I pointed out in my paper, that disc has some embryogenic potential, like that it is a remnant of a notochord. So there are recent papers which say that the WNT pathway, the Wnt pathway, which is like a pathway that indicates that any changes could affect cause like deformities or fetal defects or related to even cancer. Okay, this Wnt pathway is pointing it in a direction that there are some genetic susceptibility and which are determined during the developmental time. So the disc being a remnant of notochord could provide clues to study the etiopathogenesis. And also study why we study proteomics is because like genes are not always translated into the proteins. So proteomics could provide answers whether these genes are already translating into protein or not. It is just an exploratory study. It is a pilot study. We have analyzed only 8 discs so far. And as I pointed out, we have not done an analysis on concave versus concave side, where some studies have compared it in muscles and bones also there have been, which have been already studied.
Okay.
Hi, Dr. Vijay. One question for you. I would like to ask Dr. Vijay.
Yes, sir.
Hi, hope you are fine.
Thank
Vijay, you have told few of the genes that you have made in your paper. What are the other new genes? What are the future implication of this study? What you are planning next to the future for this study based on this study?
Yes, sir.
Because you have shown few
first
genes,
step
like
is that
you have taken out.
Yes, sir. The first step
What are
is
the
that
other genes that you have taken out from your study that you are planning for further study in your future studies?
Yes, sir. As I pointed out, we have studied only 8 discs from 3 patients. This is a pilot study. First of all, we will need to do the same analysis in a large number of discs to confirm and find out what are the statistically significant proteins that make out in a large numbers. So those particular proteins we need to evaluate and do a protein mapping and other analysis like protein-protein interactions we need to study to find out which pathway these proteins are actually involved in. That will be the next step to go ahead.
Yeah.
Okay.
So
I request
the presenters to be very crisp in answering the questions. Thanks, Srijay. So to Nishank, actually, does you have any studied?
Hello.
Yeah, Nishank.
Sir, I'm here.
Yeah, have you compared the use of dual surgeons in reducing the time of surgical time?
No, sir, that was not a part of our study. There was a single chief surgeon. So we actually compared the experience of the chief surgeon and the experience of the first assistant. These were 2 parameters which are fed into the model.
Okay. Thank you. Thank you. You want to ask anyone?
No, I have no question for them.
Yeah.
Well presented.
So, yeah. Dr. Islam, so with your experience, have you compared the surgical technique of translation with other methods and you found one technique is much better than the other?
Thank you, Doctor, for your nice question. I have a comparative study between rod derotational techniques and the axial translational techniques. And actually the correction more or less similar, but for the long time correction, I have seen that the axial translational technique is better than rod derotational techniques regarding the strength of the screw and regarding the strength of the rod as well.
Dr. Islam, can I ask one thing? Where will you not prefer this axial translational technique? What are the conditions? Where will you not prefer this technique in your cases?
Yes, thank you. If the copse angle is more than 80 or 90 degree, much more copse angle in that situation, and as well as where there is rotation is much more. In that situation, I did not like the translational techniques. As well as the age of the patient is a factor, because in adolescent idiopathic scoliosis, you know, more than 10 years, but nearer to the skeletal maturity, it is not better to be correct with these translational techniques. Usually nearer to the skeletal maturity, I do prefer rod derotational techniques and other techniques as well. That is, here in Bangladesh, we also practicing the sublaminar wiring and Herschel rectangle, though it is an older method, but we are practicing still in Bangladesh in that situation.
So let's move to the next recording, sir. Next presentation.
Now I would like to invite Dr. Vibhu. Has the COVID-19 situation revealed our next generation modality for medical consultation? Dr. Vibhu.
Good afternoon, everybody. I am here to present our study on a retrospective audit of the effectiveness and reliability of telemedicine consultations in patients with spine ailments. The COVID pandemic had posed major challenges to healthcare worldwide, and it has paved way for a recent surge in the incidence of remote telemedicine consultations. The aim of the study was to retrospectively assess the satisfaction of patients and doctors following telemedicine consultations for spine ailments. The study included patients who underwent telemedicine consultations on online platform between April and November 2020, and separate questionnaires for both patients as well as doctors were included, and the patients were classified into groups A and B based on whether they were first-time consultation patients or old or follow-up patients. We assessed in the patients with the patients 9 issues over the questionnaire, which included the satisfaction, time factor, ease of setting up of appointment, ease of communication, influence of decision making, and whether the patient would have preferred an in-person or a telemedicine visit for that particular visit, and whether the patient would opt for telemedicine in future, and if there was any specific problem. As far as doctors were concerned, again, 5 questions were asked: satisfaction, the time, ease of communication, decision-making, influence, and whether there was any specific problem. Overall, 288 patients participated in the study, of whom 223 belonged to Group A. As far as the satisfaction was concerned, 70% of new patients and 75% of old patients were very satisfied with the telemedicine appointments. The time factor was significantly different between the telemedicine appointments and in-person visits. As far as taking off of work, the patients, around 90% of patients who had to take off of work with both telemedicine as well as in-person visits. And around 79% of patients felt that they were quite comfortable communicating over telemedicine. 92% and 93% of patients were quite happy to take decisions on undergoing surgery or minor procedure based on telemedicine visits alone. And the patient, significant proportion of patients felt that they were quite happy and they would have preferred an in-person a telemedicine visit for that particular visit. And around 93.4% of patients also felt that they would opt for telemedicine visits in future. The biggest issue among the patients was the network or the connectivity issue. As far as the doctors were concerned, a significant proportion, around 88% of the doctors were very satisfied with the telemedicine services. 87% of doctors said that they were happy with eliciting clinical and history findings based on telemedicine appointments alone, and 72% could take decisions just based on telemedicine appointments. The major concern among the doctors was poor quality of MR imaging over telemedicine services, consultations. So telemedicine can involve any application which abides by patient confidentiality and enables accurate prescription of treatment. In the studies by Greven et al. And Sprova et al., significant number of patients were very satisfied with telemedicine visits. And in the study by Park et al., the satisfaction among the patients was significantly better with telemedicine visits as compared to the medical staff. Overall, in our study, both patients as well as doctors gave us excellent feedback with telemedicine appointments, and 80% of patients were really comfortable with their ability to communicate based on telemedicine facilities. So overall conclusion of the study is telemedicine is an effective alternative to in-person visits for assessment of patients with spine ailments. And in specific situations, remote visits need to be complemented by in-person visits to thoroughly evaluate the patients. Thank you.
Thank you. Now, I would like to invite Dr. Abhinandan. Is CT angiography necessary to define vertebral artery dominance, a CT scan-based morphometric study?
One of the complications of cervical spine instrumentation is vertebral artery injury, and to improve the accuracy of screw insertion and to avoid the injury of vertebral artery, knowledge of the vertebral artery dominance is a must. And cranial vasculature plays a crucial role in the forming of the cranial bony structures, and unilaterally small transverse foramen is associated with hypoplasia or aplasia of the vertebral artery. Because VA is the main anatomic structure occupying the transverse foramina, it may be assumed that the size of transverse foramen and vertebral artery should be proportional. And also, when any fixation is planned in the supraaxial cervical spine, the usual protocol is to evaluate the vertebral artery using a CT angiography. However, it is an invasive procedure with added cost and may not be widely available, especially in the resource-poor countries. Our hypothesis was that the size of the vertebral artery should correlate with the size of the ipsilateral transverse foramen. Therefore, our objective was to determine whether there is a size correlation between vertebral artery and transverse foramen. In the material and methods, it was a morphological-based study and prospectively designed and a single-center study from January 2018 to December 2019. Patients who underwent CT angiography for reasons other than evaluation of the vertebral artery diseases were selected, significant deformities of the cervical spine and vertebral artery being excluded. The list of exclusion criteria, as you can notice on the screen. Imaging analysis of the CT angiography was done. with a 64-slice multi-detector scanner, and the non-ionic contrast material ultraviolet was injected at a flow rate of 5 ml per second, followed by washing out with 20 ml of normal saline at the same rate. Two trained spine surgeons independently measured the parameters included. As you can see on the screen, we measured using the PAC system the area occupied by the transverse foramen, and similarly the area occupied by the vertebral artery. And also in the respective segments ranging from C3 to C6, we measured the pedicle width accordingly. And the parameters we considered was dominance of the vertebral artery, dimensions of the vertebral artery and transverse foramen, width of the pedicles, internal height and isthmus height of C2. And the transverse foramen is usually cylindrical in shape with its smallest diameter in its mid portion. We therefore measured the size of the transverse foramen in the cross-sectional plane. Coming to results, there were 74 males and 26 females, and the mean age was 45 years, with ages ranging from 23 to 68. And 56 patients had a left dominant vertebral artery, and 44 patients had a right dominant vertebral artery. And as you can see, the size of the transverse foramen slightly decreased as we move out from C6 to C3. Similarly, the size of the vertebral artery cross-sectional area decreased from C6 to C3 as we move along. And the pedicle width was nearly almost the same along the C3 to C6, with slight decrease along C3-4. When we went for the correlation between the vertebral artery and the transverse foramen, we can see that it is significantly correlated, and the p-value was less than 0.001. Similarly, when the correlation between the vertebral artery and pedicle width was done, they were not at all correlated and were not significant. As we can see, the correlation between the transverse foramen and pedicle width was also not correlated. Coming to discussion, the findings of our study show that the size of the transverse foramen is a key determinant of the vertebral artery. Furthermore, the left transverse foramen was larger than the right transverse foramen in our series, which is in line with the similar asymmetry of the vertebral artery dominance. And a strong correlation between the sizes of transverse foramen and vertebral artery could enable the surgeon to predict the calibers of vertebral artery just evaluating the transverse foramen on CT without performing additional imaging techniques. As such, CT angiography is an invasive procedure and requires patient to remain nil per oral up to 4 to 6 hours prior to the procedure, and patients with risk of allergy to contrast material may need close observation, steroid administration, and need for iodinated contrast. And iodinated contrast may affect the renal function. Many of these patients may be syndromic in multi-system abnormalities, including the renal function. The peri-procedure morbidity is around 4%. We found a strong correlation between transverse foramen area and area of vertebral artery, and the agreement between the dominant vertebral artery and the largest head of the transverse foramen was almost perfect. Thus, our findings demonstrate that largest head of the transverse foramen can be used reliably to predict the size of the dominant vertebral artery. Though our study results show that CT angiography is not always necessary, incidental discovery variations in the foramen transverse area in cervical spine CT should alert the surgeons for coexisting vertebral artery variations. Possible variations of the artery should be thoroughly investigated using MR or CT angiography. Conclusion: the present study suggests that the size of the transverse foramen can be used to predict the size of the dominant vertebral artery reliably, and considering the possible complications of vertebral artery injury, this study strongly recommends the preoperative use of CT angiography when a suspicion of variation is present and implied by foramen variation on through the routine CT.
So the next presenter will be Dr. Montu Jain, validation of freehand cervical pedicle screw placement in subaxial cervical spine.
Good afternoon and greetings from AIIMS Bhubaneswar, and I will be talking on validation of the freehand cervical pedicle screw placement in the subaxial spine using the soft technique. Pedicle screw are a cornerstone in spine instrumentation, more so in the thoracic and the lumbar spine. However, the cervical spine is more complicated because of its dangerous relationship between the spinal cord lying medially and the vertebral artery lying laterally. Hence, it requires a lot of precision to give a safe cervical pedicle screw, often wanting sophisticated gadgets such as navigation. So the freehand cervical pedicle screw placement was first described by Aboume et al. In the year 1994. Since then, many investigators came out with different techniques. However, in the year 2017, Bursov et al. Came out with the technique which the authors describe easy and fast method. Subsequently, no other authors have reiterated their findings, and thus we aim to validate the freehand technique described by these authors in the Indian case. So after attaining the IEC approval, 4 previously stored cadavers were utilized for our study. The Bursov technique of freehand cervical pedicle screw was used, and subaxial spine C3 to C6 was instrumentation. Post-instrumentation, a CT scan was done with the axial and the sagittal view. When there is a medial breach of more than 1 millimeter or an overlapping of more than 25% of the vertebral foramen, it was considered as unacceptable. So the entry point, as the authors have described, is 2 millimeter below and medial to the lateralmost point of the lateral mass, making an angle of 180 degree with a contralateral lamina, which is called as the laminar pedicle angle, and 90 degree in the sagittal. So this is the demonstration of screw placement in the cadaveric lab. So this is the post-instrumentation axial and sagittal view. Here screws are well placed and therefore they are acceptable. So we found that 78% of our screws were acceptable and 7 of them out of 32 were unacceptable. The laminar pedicle angle or the laminar screw angle was 173 to plus minus 4.3 degrees, and the sagittal angle was almost 88.15 degree plus minus 4 degrees, and this was without the use of C-arm guidance in our cadaveric lab. So there have been many methods to describe freehand cervical pedicle screws, and these authors have described some tips, tricks and also trajectories to avoid pedicle breach, but these free techniques are yet to become popular among the spine surgeons in want of sophisticated gadgets such as navigation and robotics, which come at a huge. Coming to the literature review, Abumi et al. First described in 1994 regarding a freehand technique and they did in a clinical patients. The author used initially a burr to enlarge the entry hole and subsequently with an angle of 25 to 40 degree medially. Generator also did a cadaveric study and later on also did a clinical study with 3 patients, and their entry point was almost very similar, making an angle of 45 degree. Miller, however, warned and advised for a partial laminectomy to probe the pedicle. Ibrahim also did a cadaveric study in the year 1997, which was clinically proven by Zhu et al. In the year 2009. Bursov et al. In the year 2017 described the present technique, which we have also done in detail. And it was Lin Bin in 2020, who came up with a new type of technique, which is called as a sliding technique. So our study was limited by having only a cadaveric study and there is no clinical validation till now, and the formalin preserved bones are softer than the actual dried bones, which has precluded the tactile perception in some of the features. So to conclude, Bursov technique is very effective and reproducible as the landmarks are easily identifiable. When we use tricks and trips given by other investigators such as initial deep burring or use of small probe, sliding technique, and even the use of fluoroscopic guidance, the safety margin will definitely improve. Thank you.
The next speaker is Dr. Sudarshan for spinal dural AV clinical character.
Good afternoon, all. Greetings from CMC Vellore. I will be presenting about the clinical characteristics, outcomes, and long-term follow-up in patients with spinal dural AV fistulas managed in our institution over the last 2 decades. Spinal dural AV fistulas represent an abnormal connection between a spinal radicular artery and vein, typically at the dural sleeve of the dorsal nerve root. They are the most common spinal vascular disorder, accounting for nearly 80% of such cases. They are insidious in onset, difficult to diagnose, and present with profound neurological deficits. They present one of the most treatable causes of progressive myelopathy and managed both by microsurgical as well as endovascular means. Our aim was to study the clinical and radiological characteristics of spinal dural AV fistula and compare the outcomes between microsurgery and endovascular intervention. Here we present our retrospective consecutive case series of 76 spinal dural AV fistula patients who underwent microsurgical or endovascular management between January 2001 and 2020. Clinical characteristics including the patient's age, sex, duration of symptoms, examination findings were studied along with the radiological features. Functional outcomes were assessed with neuric grade and the patients were followed up for recurrence or change in neurological status. Male to female ratio was found to be 18:1 with a mean age of 52 years. Myelopathy and bladder involvement was present in nearly 90% of patients at the time of presentation. As shown in the picture, the fistula was present in the thoracic region among 72% of the patients, followed by lumbar region in 24%, while 3 cases were of sacral and iliac origin. Mean follow-up was 3.5 years in the microsurgical group, while it was 3.7 in the endovascular group. In our series, majority of them underwent microsurgical disconnection of the fistula, and we noted that the success rates were better in the microsurgical group, 95% as compared to 83% in the endovascular group. We noted that the recurrence rate was also more in the endovascular group, ranging up to 36%, while it was a meager 5% in the microsurgical group. It is prudent to conclude that microneurosurgery has better superiority in terms of better outcomes and lesser recurrence rates as compared to the endovascular technique. Sudden deterioration of neurological status preoperatively after starting steroids was seen in the microsurgical series. None of the patients in the endovascular group had deterioration preoperatively as they were not started on steroids pre or post procedure. Administration of IV or oral steroids preoperatively results in the shift of oncotic balance with altered renal dynamics with subsequent water reabsorption and shunting of blood in the venous circulation. This, in the presence of coexisting venous hypertension, leads to worsening cord edema and ischemia, explaining the sudden deterioration. Univariate analysis showed no significant prognostic factors affecting the outcome. The average time delay in diagnosis was found to be at least a year, 26.6 months to be exact. Postoperatively, there was overall stabilization of disease, with 92.7% of the cases either improving or remaining the same as the pre-intervention state. As seen in this table, 63% of the patients had an improvement in uric grade by 1 or more points. These are the various series published in literature which support microsurgical disconnection of SDAVFs. In our personal experience, we were able to achieve 95% obliteration rates with 4.8% recurrence at a mean follow-up of 42 months. This was in line with results published in literature. We see here a set of endovascular series. Though our numbers were low, the success and recurrence rates were comparable. Various studies published in literature show that a success rate ranging from 56 to 80% with higher recurrence rates of 70 to 40%, and many requiring intervention in the form of repeat embolization or microneurosurgery. I would like to conclude that microsurgical disconnection of spinal AV fistulas was associated with lesser recurrence rates, higher obliteration rates, and leads to a better outcome of functional status. Endovascular embolization is another option that can be considered in select cases. Thank you.
So I would call upon the last speaker of this paper session, Dr. Habum, for the management of Atlanta Axial
Our
Instability.
last presentation is from Dr. Habam.
Good afternoon, everyone. Today I am going to present management of atlantoaxial instability in pediatric age group up to 7 years of follow-up. Diseases of craniovertebral junction and upper cervical spine are more common in pediatric age group more than in adults. Most spinal injuries in children younger than 8 years of age occur above the level of C4. Management varies from non-operative to operative intervention depending upon age, presenting symptoms, neurological involvement, and degree of instability. We reviewed 8 consecutive patients with atlantoaxial instability who presented to our institute between 2013 to 20. All patients were investigated for underlying etiologies and radiologically for degree of instability. They were managed either conservatively or surgically, transarticular screw fixation or occipitocervical fusion. Functional outcome was assessed using ASIA score and neck disability score, and radiological assessment was done on radiographs for fusion. Out of 8 patients, 3 were boys, 5 were girls, with mean age 7.6 years, range between 1 to 14 years. 3 patients had congenital atlantoaxial rotatory subluxation, 2 had atlantoaxial instability secondary to Down syndrome, 1 had Hurler syndrome, 1 was post-infective, and 1 had congenital occipitalization of atlas with hypoplastic C1 arch. Most common presenting symptoms were continued neck pain and torticollis. 4 patients presented with difficulty, inability to walk, and neurodeficit with exaggerated reflexes. All patients were investigated preoperatively with plain radiograph, epilateral and open mouth. Dynamic views like flexion extensions were taken, CT scan, cervical spine 2D plus 3D, and CT angiography to look for vertebral artery and other major vessels were taken, and MRI cervical spine with whole spine screen. 1 patient was managed conservatively while the remaining 7 were managed surgically. 2 patients with transarticular screw fixation and 5 with occipitocervical fusion using either hard shell, which was in 1 patient, and occipitocervical in remaining 4 patients. 4 patients who had preoperative neural deficit improved over 3 months of postoperatively, while in remaining 4 preoperative and postoperative neurology was normal. All patients improved symptomatically. Functional outcome was assessed using ASIA score and WAS score, and radiological assessment was done on radiograph for fusion. Follow-up period ranged from 1 year to 7 years. Atlantoaxial instability is not uncommon among pediatric age group and can lead to serious complication if neglected. Diagnosis in syndromic child need high suspicious and detailed clinical evaluation. Imaging is critical for diagnosis in doubtful cases. Thorough preoperative radiological planning on CT angiography and 3D CT model will help in better visualization of complex anatomy and carry out surgery with excellent outcome. These are the tables. And here we have case of 10-year-old female case of traumatic C2 fracture with C1, C2 subluxation operated with occipital cervical fusion using heart seal. 7-year follow-up was taken. 8-year-old female case of C1, C2 rotatory subluxation operated with occipital cervical fusion using occipital. Late 2 years follow-up was taken. This is pre-op and post-op analysis. Thank you.
So that was an excellent session. Dr. Vibhu. Yeah, hi. So this is an excellent, completely different study which you have done. So looking at the study, we could see that the patient and as well as the doctor is completely satisfied in doing telemedicine. So do you think this COVID-19 pandemic has made that option, like there is no other option and that made them happy, or this could work even in future also?
No, as I had mentioned, 90% of the patients also said that they would have had or preferred a telemedicine appointment for that session even later. They said they would prefer. Quite a good number of patients were happy to go in for telemedicine consultations in future too. We still continue telemedicine appointments quite frequently at our institution, and it seems to be a good way ahead.
Dr. Vibhu, where are your patients are dissatisfied? You said there about 83 to 85% patients are satisfied with your telemedicine. And what are the commonest problems that the patient encounters where the patient are dissatisfied with this telemedicine?
Yeah, the most common issue was with the network. Patients from
that you have
that was hello.
It was actually reflected here.
There is some network issue.
Yeah. So the network and audio issues were the most common issues from the patient's point of view. Apart from that, some of the patients said they had issues with the payment modality. This was in the initial few days, but later on it settled down on the mode of payment. And sometimes the patients felt that they didn't have enough intimation because they weren't ready 10-15 minutes before, so they were joining late or some delay from our side. And the other one was basically with the patients feeling that they would have, if they had come in person, they could have watched some videos or more information as compared to online. Otherwise, the most common issue was with the network.
Thank you, Dr.
Thank you.
Dr. Munjal Shah. So the you have used this anabolic teriparatide for osteoporosis to avoid a revision surgery. So what is your general protocol for using this teriparatide?
Thank you, sir, for your question. Sir, generally when we see patients in which the implant-related complications are there and there is instability pain, we do our criteria of selection, which I mentioned in our talk, and we see whether there are no contraindications for teriparatide, and they should be de novo, should not be treated for osteoporosis before. In this, we try to sell them that this can save. It was like a study in which we started with one patient and we continued with the consecutive patients who were reluctant for treatment for surgery. And we consecutively find that they were holding the implants and their VAS and MODI scores were getting better, sir, with time. And they are still holding.
Because the teriparatide starts working after some.
Yes, sir.
It's time for it to act.
Yes, sir. So we call them. Yes, sir. We call them at 3 months unless there is neurological deficit in emergency. And at 3 months, if they are improving, we try to extend from up to 18 to 24 months, sir. And after that, we stop them and we follow till December 2020 is like 16 months follow-up we have. And now we are extrapolating for other patients also.
Thank you.
Thank you, sir.
Dr. Sudarshan, so with respect to your microsurgical technique for AVM, was there any randomization done between these two groups?
No, sir. We had taken all the patients who had come to our center, and we had assessed all the 76 consecutive patients who presented to us with this condition, spinal dural AV fistulas.
Okay. So there was something like you prefer for one particular set of patients, you do a microsurgical procedure, others you do an embolization sort of thing, or?
No, sir. The first preference is always given to surgery. The affordability is a major issue when it comes to the intervention and embolization. So, there was no randomization done between the two groups. And if you see, only 14 cases were available for us in the endovascular group. That is one of the reasons why we had a lesser number in the endovascular group.
Yeah. So the microscopic procedures actually give a good outcomes. There will not be any recurrence in those things, but this one is having a lot of difference, but yeah, thanks. Sure, anything else?
Are there any more questions for these speakers from the audience? No, I think the boys have done a fabulous job. Don't you agree, Dr. Ramchandran? Dr.
Yes, excellent, sir. Excellent.
Very nice presentations, very good on time, and excellent research work. Keep it up. ASSI congratulates all the panelists, all the speakers in the session, and we are very happy with the excellent research work you are doing. Keep it up. I would like to end this session by thanking Dr. Ramchandran and Dr. Waliullah Shah for their excellent moderation of the session. They managed to keep it live and interactive and yet managed to keep it on time. I thank them for their help, and I hand it back to Neeraj and the hall moderators, MCs, to lead us on to the next session of free papers. Just to remind the judges, Dr. Ashish Jaiswal and Dr. Arun Kumar, this session consists of 15 papers. They are 2 minutes each. After every 5 minutes, after every 5 papers, we take a 10-minute question answer and then go to the next five set of papers. Okay, thank you very much. And
thank you, Gautam sir. Thank you, Gautam sir. So we go on to the next session. The session is free paper session. As Gautam sir told, 2 minutes of presentation and 2 minutes of discussion. But we'll take up after every 5 papers we can take. Then I would like to invite the moderators, Dr. Arun Kumar Vishwananda and Dr. Ashish Jaiswal.
Yeah. Good afternoon, everyone.
Good afternoon, Dr. Arun.
Let me take over the session now.
Yeah.
So, can we start the session right now?
Yes.
You can start.
Sure. So, let me invite the first speaker, Dr. Syed Iftikhar, and the topic is about comparison of outcomes of dorsolumbar and lumbar spine tuberculosis treated by open and minimally invasive techniques, a prospective study.
My topic for today's presentation is comparison of outcomes of dorsolumbar and lumbar tuberculosis treated by open and minimally invasive techniques. So the need for surgery in lumbar and dorsolumbar tuberculosis is persistent spinal cord and nerve root compression or spinal instability due to kyphosis, continued disability not responding to conservative treatment. So minimally invasive surgery, which has been in the recent years, the advantages of that being less bleeding, less operative time and early rehabilitation. The aim was to compare the outcomes of minimally invasive and open techniques treated in lumbar and dorsolumbar tuberculosis. Our methodology was 38 patients, 14 treated by MIS and 24 treated by open methods, and these were the outcomes. Inclusion criteria, we included active spinal tuberculosis and excluded healed tuberculosis, and these were the other exclusion criteria. Coming on to the results, the baseline characteristics of both the groups were comparable. There was no significant difference in both the groups. The age group was comparable, and the clinical parameters, there was significant improvement in both the groups when VAS, ODA, kyphotic angle, and mean kyphosis correction was compared. But when we compared both the groups of MIS and open techniques, we found that the blood loss and kyphosis correction there was significant difference in these two things, where the blood loss was significantly less in MIS group and kyphosis correction was significantly more in open group. And this is how the neurology fared at the final follow-up. And the top group is MIS group and the bottom group is open group. And these are the complications that we had in our group, the top one being the MIS and the bottom one being the open group. Coming on to the conclusion, both the groups had significant improvement in VAS and ODI scores. The only difference was blood loss, deformity correction, and rehabilitation. Blood loss was significantly less in MIS group, and deformity correction was significantly more in open group. MIS techniques, when done in selected cases, they give a comparable outcome to open techniques, which are gold standard. And MIS can be chosen in selected cases. Thank you.
That was a good paper. So we'll move ahead to the next presentation by Dr. Raj Sakrekar. It's about the improving safety, accuracy, and reliability in placement of thoracolumbar pedicle screws using OAM-based navigation system, a single center analysis of over 1,400 pedicle screws in Indian population.
Good morning, everyone. I'll be talking on improving safety, accuracy, reliability in placement of thoracolumbar pedicle screws using OAM-based navigation over 1,400 screws. Pedicle screws constructs have gained much popularity as per Gaines et al. Discussed in JBGS, but they have lingering concerns about misplacement varying from 5% to 55%. They can give rise to neurological deficit, vascular deficits. Not only that, they can give to medical implications also. They have various concerns of radiation causing from inflammatory to tumors. The accuracy of current CM and 2D navigation and 3D have accuracy issues. So we wanted to study accuracy of OAM with navigation. A patient who were studied, operated in Kokilabane from 2017 to 2020 in Mumbai were included in the study. It was a retrospective study. We used Gutsman classification for analysis. This is the OT picture. So it helps in projecting the accurate placement of the screws. It helps the trajectory. We can check the pedicle length. We can put the medial converging and strongest outer screws presenting few of our cases. It can be very helpful in deformity cases, in degenerative cases, in revision spine cases, as well as in difficult tumor cases. Coming to the results, it has shown accuracy as high as 98% thoracic and 99% in lumbar screws. Coming to the discussion, our results were equivocal with other studies. Hence, it has also reduced the radiation exposure to the OT staff as well as to the patient. It also reduces the cost considering the decreased revision rate, operative time, and hospital stay. Hence, to conclude, use of OAM-based navigation can improve your safety, accuracy, reliability. It also reduces the exposure to the staff as well as the patient. Thank you.
Okay, that was a good one, pretty rapid one, of course. Let us go to the next paper by Dr. Hriday P. Acharya, and it's about Are we our own patients? Neck pain in spine surgeons, its prevalence and risk factors.
Good afternoon, I'm Dr. Hriday Acharya, and today I present to you our study, Neck Pain in Spine Surgeons, Prevalence and Risk Factors. Are we our own patients? Neck pain is a well-known professional hazard, and it's more common amongst doctors because of the awkward posture of the neck, long working hours, and working techniques. Here, we conducted a study to determine the prevalence and risk factor of neck pain among spine surgeons. This is the first study done in our country. A survey questionnaire was sent containing various questions about demography, neck pain, and work practices to 300 spine surgeons using text messages and emails. The questions contained various sections regarding demographic data, neck pain type, frequency, if medication was needed, the kind of work they did, use loops, microscopes, or naked eyes, the lifestyle and investigation that was done, and treatment if it was taken. 180 spine surgeons responded to our study, of which 4 had already been operated for cervical spine surgeries, and 134 of them had neck pain, which means the incidence was 74%, which is pretty high. The various other data was that 134 had neck pain, most common age group was 30s, lifestyle varied from exercising thrice a day to infrequent exercises. Most of them operated using naked eyes. There was no stable height preference. The most common OPD about 20 to 30 hours per week and 10 to 20 hours a week were scrubbed in the OT. 45 spine surgeons had already been investigated with X-rays, MRIs, and CT scans. Only 2 factors came out to be significant, which was lifestyle. Those who exercised more than thrice a week had less neck pain, and those who used microscopes had less neck pain as compared to those using loops. When comparing general population, the incidence is as low as 23%, and other surgical subspecialties varies from 47 to 60%. Spine surgery is as high as 74% as found in our study. So only 2 things were important, which was lifestyle and work style. There have been various studies which shows that the lifestyle, as in inactivity, causes significant neck pain, and working practices like using loops had more incidence of neck pain as compared to microscope. Most ergonomic was using microscope with a table height at umbilicus level. Hence, to conclude, spine surgeons have higher prevalence of neck pain as compared to general population, and ergonomic guidelines need to be recommended, which should include operative methods in intermittent rest during operations and work fitness balance. Thank you.
Okay, that was a good one. So let's move on to the 4th paper by Dr. Tarun Chabra. This is about cauda equina syndrome retention type, outcome after delayed discectomy and decompression for lumbar disc herniation.
Dr. Tarun has not been presenting on the cauda equina syndrome retention type, outcome after delayed discectomy and decompression for lumbar disc herniation. So it's a retrospective study which to study the functional outcome after lumbar discectomy in CSR patient with delayed presentation. Cauda equina syndrome due to flap intravertebral is a rare phenomena causing neurological deficit that is permanent. Timing of surgery within 48 to 72 hours of the symptoms. There is problem in the delay in the management and optimum time of the surgery is a dilemma. ASSA is classified into 3 types: cauda equina syndrome, suspicious, incomplete, and with retention. The second is the loss of the visceral neurological signal to the CNS, causing painless urinary retention and overflow, incontinence, and dysfunction of the bladder. In our studies, 27 patients were there, included 14 patients, excluded 12 patients, 1 patient was lost to the follow-up. All patients had low back pain and radicular pain. Multiple variables recorded, all underwent open discectomy and extensive decompression. Bladder function noted into 3 categories: complete, partial, and no recovery. Bladder dysfunction was seen through urinary symptom profile. Ball dysfunction was also noted through neurogenic ball dysfunction, and sexual dysfunction noted in male and females. SF12 was used for MCS and PCS. Employment status was noted. Preoperative clinical demographics: 9 males, 5 females. Mean age 35. Most common level was L4, L5. Average follow-up was 30 months. WAS score improved in low back pain and leg pain. ODI also improved. Motor function complete. MRC grade 5 in 5 patients. Partial sensation in 5 patients. WAC and PS was noted. No patient diagnosed with CSR who had normal WAC. Restoration of bladder function complete in 8 patients, individual catheter in 3 patients. Ball complete return in 7 patients, no recovery in 2 patients. Sexual dysfunction was also noted with SSD scores and dysfunction. Patient with bladder and ball symptoms had low PCS and MCS scores. All patients, out of them 5 went into previous employment, 6 were unable to work. Limitation of the study is a retrospective study with preoperative sexual history was not obtained. Low number for the statistical analysis. Validated questionnaires provide guide for the outcome in the clinician. It was noted that recovery of the bladder and sexual function was worst affected. Thank you very much.
So let's move on to the next topic, as Dr. Tarun is not available at this moment. So the next topic is by Dr. Shashidharan. It's about clinical efficacy of selective nerve root block in management of lumbar radiculopathy.
Good morning. I'm Dr. M.D. Shashidharan, ASSI Spine Fellow, Apollo Hospital, Chennai. Clinical efficacy of selective nerve root block in management of lumbar radiculopathy. The current study aspires to assess the functional outcome of selective nerve root block in patient with lumbar radiculopathy, whether we can stave off the possibility of surgery. If not, then for what amount of time can we postpone the surgical management? To study the functional outcome of patient with posterior intervertebral disc prolapse, lumbar canal stenosis, and lumbar radiculopathy after selective nerve root block at a corresponding level. Indication: lumbar radiculopathy, neurogenic claudication. Contraindication: infection, bleeding disorders, cauda equina syndrome, patient refusal. Outcome measures using ODI, SLR, and NRS. Study: hospital-based prospective cohort study, duration 18 months. Inclusion criteria: patient with lumbar radiculopathy for more than 3 months and SLR 30 to 60 degree. Exclusion criteria: infectious conditions, vertebral instability, pathological fracture, isolated back pain, bilateral symptomatic patient, neurological deficit, multiple level spinal pathologists. Procedure: daycare procedure under image verification. 18 gauge needle used, dye used, 2 ml bupivacaine and 1 ml triamcinolone was injected. 113 patients were included. 1 or 2 were intervertebral disc prolapse, and 11 were lumbar canal stenosis. Results were assessed immediate procedure 3 weeks and 3 months. Mean SLR, mean ODI, and mean NRF was statistically significant. 25 patients underwent surgery because they did not have any relief in back pain or leg pain, and patients with lumbar canal stenosis all underwent surgery. Out of 113 patients, 88 patients had a good outcome. There was no significant complication. The limitation was the study population and the study period was less. The significant functional improvement, both statistically and clinically, in patients with intervertebral disc prolapse after giving selective nerve root block was found. Patient with lumbar canal stenosis did not have good outcome. Patient with selective nerve block after 6 months did not have good outcome. 80% of the patients had good outcome of the procedure. We conclude that selective nerve block is a good therapeutic procedure for pain management in patient with lumbar radiculopathy, and it can be used as a standard procedure before advising any form of surgery. Thank you.
So we can take questions now, sir.
So I would like to ask.
Tarun is also here. Tarun is also joined.
Okay. I would like to ask Dr. Raj, who presented on OARM. You said that OARM decreases the radiation to patient. In fact, I feel means for regular thoracolumbar fractures, you hardly need any radiation, 1 to 2 shots. So how can you say means after scanning with OARM, the radiation will be reduced to patient?
Yes, sir. So we compared, as I quoted the paper of Watkins et al. And Gupta et al. They have mentioned for one of the MIS techniques, one screw takes at least fluoroscopy time of 10 to 15 seconds, and one MIS still if hole will take about 90 seconds, while the OARM, the fluoroscopy time is as less as 15 to 25 seconds. So at the end of, if you see, there is definite less exposure to the patient at the end of the surgery, sir.
So maybe that is specific to MIS. I think in open surgery, of course, freehand has less radiation, far much radiation.
Yes, sir. Yes, definitely. The surgery for patient is just one-time exposure to the CT, while the surgeon is exposed daily, means in throughout the year. So considering that scenarios in MIS cases and considering the MIS coming up big time, everyone is doing MIS more and more cases. MIS's fluoroscopy time being reduced. So I think OARM is going to stay, sir.
And this is another question to Shashidharan. Don't you think SNRB is not a very good option for stenosis, as suggested by your results also? Because probably yes, I think caudal epidural is a better option, because here the root is not the pure issue. It is more of a canal diameter.
Sure, sir. We have tried caudal epidural also, but in our study we took up patients for canal stenosis, so that we wanted to prove that canal stenosis cannot be treated with SNRB, and we also wanted to prove that disc prolapse has a good result with SNRB, sir. The previous studies we have studied, but we wanted to prove that, sir.
Okay. Okay. So Dr. Syed Iftikhar, who is there?
Yes, sir.
Yeah, you have compared both the techniques of MIS and open for tuberculosis. With the MIS technique, don't you think the amount of biopsy taken is compromised or inadequate at times?
No, sir, definitely not. By the amount of cases that we have operated, it was 14 cases that were completed, and recently we have done 3 more cases. So in all the cases, in MIS, what we do is we shave the interbody area. We get a lot of material from the interbody area. And that is where I think the pus or the histopathological specimens that we get in. So it is from that area that we get in. And even in MIS, we get sufficient amount of material for histopathology as well as for culture and sensitivity. So that was done in all the patients. And we did not face any kind of difficulty in as far as the amount of sample was concerned.
Okay, that was good. And you said MIS technique is to be used in selective patients, and any indications for selecting those patients particularly?
Selective patients, as in supposing we have a multifocal contiguous pod spine involving 3 to 4 vertebral bodies where there is gross destruction, where there is severe kyphosis. So we have not gauged the amount of kyphosis. Before this amount of kyphosis, you can use MIS, and after this limit, you have to use open techniques. But what we studied from our study was if there was severe kyphosis involvement of multiple segments, then it was difficult to get through or get the results with MIS. So we have done that in open techniques. And even our result states that kyphosis correction is better in open techniques when compared to MIS techniques. So I think that is one of the important criteria that we took while selecting these patients.
Great. That was a good paper indeed.
Thank you, sir.
The next one was about Dr. Hriday Acharya. Yeah, so you said the prevalence and risk factors are increased for the spine surgeons for getting neck pain subsequently. So any recommendations for those particular spine surgeons?
Sir, we had 3 recommendations. First was that if possible ergonomically and in a hospital to use microscopes if you are using loops. So the other was regarding frequent physical activities in terms of exercises or any like walking at least thrice a week, because that was something that was significant, and intermittent rest. There has been a paper that has been published which says that taking 15 seconds or 20 seconds of rest every 5 minutes or 2 minutes rest every 15 minutes during operations can significantly reduce neck pain in surgeons.
Yes, actually that was my paper.
Yes.
The published paper. Yes, that was about I ask you. So you have done this prevalence and risk factors. Other than that, you did not see the ergonomics of the patient, of the surgeons.
Ergonomically, sir, we did study, but there was nothing that was significant. We asked everybody regarding the table height also, that what was the preferred height, but most of them were not very specific about the height. That was so most of them answered like the comfortable height is what we also kept as an option, because we generally don't keep it at an umbilicus level when we operate. It's just like wo jo bhi comfortable rehta hai udhar rakhte kind of. This is the comfortable height is what they preferred, most of them. Even loops versus microscope, most of them use naked eye. When we compared loops and microscope, that is when we found that those using loops had more neck pain, but most of the population in the country use naked eyes for operating. So there were also OPD and OT working hours, because most of the doctors in our country have been working a long time, but even that didn't come out to be significant when comparing non-patient surgeons who did not have pain.
Great. Good paper indeed. Thank you.
Thank you so much, sir. I would also like to ask whether wearing a thyroid shield makes any difference to the neck pain. Did you inquire into that? Just like
thank you, sir, for the question. We did not actually have this question in the format that we had made, but since head loops have more weight, even that might be an effect, but we did not have any question in so we could not comment on this.
Okay. I think that needs to be studied. Yeah.
So it might lead to upper neck or lumbar pain because the thyroid shield, maybe head loops would be more significant. Just a thought.
Good. Any other questions from the audience? Yeah, I think if not, we can move on to the next paper presentation. So the next paper is by Dr. Manoj Kumar Ramchandraya. It's about a survey of low back and neck pain and associated risk factors among nurses.
Good evening, everyone. My presentation is about a survey on the prevalence of low back and neck pain and associated risk factors among nurses. Back and neck pain account for 6% of all direct cause of morbidity, 15% of all days off work sick, and 18% of all early retirements in developed countries. Although occupational factors may initiate neck and back pain, psychological factors appear to play a very important role in the severity and resultant disability caused by pain. So this study was basically undertaken to ascertain the prevalence of neck and back pain among nurses and to study its correlation with various anthropometric factors, educational qualification, travel to work, area of work, and sadness and depression. The study was conducted using a cross-sectional study design on 2,240 nurses using a semi-structured questionnaire in 11 hospitals between Jan and March 2020, and data collected was entered in Excel software and analysis was performed using the R software version, and p-value of less than 0.05 was considered statistically significant. The questionnaire had 3 sections. The first section sought demographic, anthropometric, and educational information. Second section dealt with activity levels at work, mode of travel, and duration of travel. And third section pursued details of prevalence of sadness, neck pain, and back pain in the last 6 months. So most of the nurses who undertook the survey were females. We divided the group into 2 groups. One group where the nurses complained of back pain never, rarely, or often, and the second group where they complained of back pain most of the time and all the time. So when correlating the different factors and its association with back and neck pain, we found out that gender, age, BMI, education, and time travel to work and hours of physical activity did not have a significant correlation with neck or back pain, whereas sadness and depression had a very significant correlation in the prevalence of back and neck pain. So to conclude, the prevalence of back and neck pain is high among nurses. Mental health issues play a very significant role in the perpetuation and exacerbation of neck and back pain, and hence assessment and treatment of mental health issues should form a part of multidisciplinary management of chronic neck and back pain. Thank you.
This is one of the few presentations I have seen where the participants are nurses rather than doctors. So the next paper presentation is by Dr. Thomas J. Kishan. This is about temporal pattern of pain and disability following the administration of a selective nerve root block in the management of lumbar disc herniation with radiculopathy.
Good day to you. We are aware that lumbar disc herniation with radiculopathy has a favorable natural history, and this study was conducted to analyze the temporal pattern of change in pain intensity and disability associated with lumbar disc herniation with radiculopathy following the administration of a selective nerve root block, and also to analyze the effect of depression, anxiety, and stress on the outcome following selective nerve root block. 50 patients with radicular leg pain and MRI evidence of disc herniation underwent a selective nerve root block. 42 out of the 50%, that is 84%, of the patients did not require surgery at 3 months follow-up. When we looked at the numerical score for leg pain, we found that the leg pain reduced from a score of 7.7 pre-injection to 2.3 within 30 minutes following the administration of the injection. We found that the back pain reduced from 7.5 pre-injection to 3.1 following the administration of the injection. And the ODI of the 42 patients who underwent surgery reduced from 59.4 to 26.3 within 3 months following the administration of the injection, all of which were statistically significant. We also found that patients who had a higher score of depression, anxiety, and stress on the DAS21 did not do as well following the administration of the nerve root block. And in conclusion, I'd like to say that selective nerve root block does provide early and sustained relief of radicular leg pain, and hence it should be administered early in the course of the disease to reduce the duration of pain and suffering. But it must be remembered that anxiety and depression have a negative effect on the outcome following selective nerve root block. Thank you.
Thank you. So the next presentation is by Dr. Srinivas Balagani, results of conservative management in low-grade lytic spondylosis.
Srinivas's presentation is not there, so we are going to the next.
We'll move on to the next presentation then. This is by Vishal Manhar Kumar Dindod. This is about multi-rod constructs in thoracolumbar spine, technique, indications, and outcomes.
Good evening, everyone. Today I am going to present my presentation on multi-rod constructs in thoracolumbar spine, technique, indication, and the outcome. Why we require multi-rod is we have developed a system from the decade. From the recent study, we are going to understand that the multi-rod associated with the increased biomechanical stability and the fusion rate, and there is a less chance of the thoracolumbar pseudoarthritis and the rod breakage. Introduction: traditional two-rod technique is a conventional use as a posterior assembly to stabilize the thoracolumbar spine. However, the rod failure and the rod breakage is well known, especially in the context of the challenging situation like orthotomy, anti-column deficit, lump fusion, and the spinal flex fixation. Multi-rod application as a concept that has gained popularity in such situation. The purpose of the study to describe a technique and determine the indication and outcome of the multi-rod construction and stabilization of the thoracolumbar spine. It is a retrospective review of the data performed over a period of 4 years between 2016 to 2020. Total 34% has been included in this study. The mean age of the person was 56 years with a 90 male and a 16 female with a 20 with minimum follow of the 24 months. Out of the 34%, 30% having the hypertension, 25% having the diabetes mellitus, arthritis and 2% associated with the osteoporosis. And out of this, 26% undergo primary fusion and 9% undergo the revision surgery. Estimated metasurgical blood loss of the 450 cc with the operative time of the 166 minutes with the no any percent developed the dual tear with the main hospital stay was the 5 day and mobilization started within third or the fourth day. No any percent develop any pseudoarthrosis, any implant related complication like implant failure, proximal junction kyphosis, no any percent of the distal junction kyphosis, or no any percent require revision surgery. Only 1% of the wound denses and 2% of the uni-tech infection. Conclusion: the advantage of the single posterior exposure, evidence of the mobility of the anterior approach, and promising short-term result accompanied with the minimal complication will provide confidence to recommend application of the multi-row construct in a selected cases with the weak anterior column.
That was a good one. So let's move on to the next speaker. This is by Dr. Raju Surgani, and the topic is about computer tomography based morphometric analysis of C1 C2 vertebra to evaluate safe corridors for anterior transarticular screw fixation.
Hello everyone, I am Dr. Raju Surgani, Spine Surgery Fellow at Rohilkhand Medical College. My topic is CT-based morphometric analysis of C1 C2 vertebra to evaluate safe corridors for anterior transarticular screw fixation. Atlantoaxial articulation is unique, mobile, ligamentous supports and integrity of odontoid for stability. Aim of this study is to assess safe corridors for TAS passage. Retrospective study was done of 50 patients, 40 males and 10 females. C1 superior facet angle, inferior facet length and inferior facet width C1, superior AP diameter and AP end plate diameter, width of C2 vertebral body, anterior height and posterior height of C2 vertebral body, distance between mid-sagittal line of C2 and medial border of vertebral artery groove. Mean age of the patients was found to be 38.9 years. Morphometric analysis has been shown in this figure. Among all cervical vertebrae, C1 and C2 forming a complex joint named as atlantoaxial joint. In current study, out of 9 measurements based on CT, no statistical significant difference on both right and left side has been found. Therefore, shape of the inferior facet of C1 was considered to be slightly oval. In this study, it could be stated that height of C2 vertebral body was more in the anterior spine than in the posterior spine. Anterior atlantoaxial transarticular screw fixation can be used as an alternative to posterior transarticular screw fixation for achieving stabilization and fusion at C1, C2.
Okay, so now the 5 papers are completed, so I think we can move over to the discussion time.
I have 2 questions for Thomas. Hi, Thomas. Of the 58
Dr.
patients,
Thomas, I think you have to unmute yourself first.
I have unmuted myself from here. Can you hear me?
Yeah, we can hear you. Dr. Thomas has to unmute.
Okay.
Dr. Thomas, are you here?
He's there, but he's not unmuting, I think.
Thomas is there, but he is not unmuted.
Okay, I think before he unmutes, we can go on to the next question to some other speaker. So my question to Dr.
Arun, you have to be a bit louder.
Me? Yes. Okay.
Yeah.
So this is to Dr. Raj Surgani. He's there. So this is your morphometric analysis. Did you find any difference with the
am I audible, sir?
Yes, you are. So can you enumerate your morphometric analysis? Your slide just
Yes,
ran out.
sir. Basically, most commonly posterior approach is taken for C1, C2 screw fixation, but there are quite a few advantages of anterior one. Am I audible?
Yes, yes, you are.
Yes, yes.
Please go ahead.
So we decided to do a study on 50 patients, 40 were male and 10 female. And we found that due to high vertebral artery position, there is quite a risk in
posterior artery, posterior approach taken for C1, C2 screw placement, particular screw, articulation screw placement.
Okay. Okay. I think
the study was done by CT, sir. NCCT.
Okay, that's fine.
Thomas? I think he's busy. Maybe
he's still unable to mute. Okay. About the multi-rod constructs by Vishal Manhar Kumar. If he's here, did you compare your multi-rod constructs with the 3 or 4? How many rods did you use?
Hello, sir. Good evening, sir. We have mostly the 4 rods, sir. One rod on each side, sir. Parallel to the primary rod, sir. With the use of the dominus, sir.
Okay, so 4 rods totally.
Yes, sir. Total 4 rods, sir.
Okay. Have you anywhere tried a 3 versus 4 rod construct with the biomechanical stability and all?
Sir, we have used.
Did you find any difference between those?
Yes, sir.
Did you find any difference with these 3 rod constructs and 4 rod constructs?
Sir, the 4 rod constructs and it is almost same, sir. But the 4 rod constructs provide more stability, sir.
4 rod gives you more stability. Okay, fine. I think the next one with Dr. Manoj Kumar, if he's here. You've spoken about the risk factors and low back and neck pain among nurses, but what I feel is different. There are different nurses doing different type of works. A floor nurse does a different type of nurse. A scrub nurse does a different one.
Sure. Yeah, sir.
So, did you find any difference between these particular groups?
Actually, we tried to find out the prevalence of lower neck pain in different area of work, sir, like OPD, ICU, OT, and all. But there was no statistically significant correlation with the area of work and neck and back pain, sir.
Okay, so one who is assisting a surgery is having the similar kind of a pain to one who is working in the OPD, according to your paper, is it?
According to our study, yes, sir. Yes.
And how could you say that nurses have a higher prevalence of neck pain and back pain? Did you because you didn't have any comparative group, I suppose?
Yeah, we didn't have a comparative group, sir. But when assessing all these factors, we found out that like sadness and depression was the main associated factor with neck and back pain, sir.
So do you feel that sadness and depression is high in nurses?
So according to our study, it looks like sadness and depression is more among nurses, and it should be tackled, sir. Like psychological pain counseling and things like that should be done in order to.
Are you available?
Sorry, sir.
Thomas is not available. Okay. Should we move to the next leg of this session?
Thomas has joined.
Yeah, I think if he joins, we have a couple more minutes for the discussion. We are on
Thomas,
time.
can you hear us?
I don't think he is not able to unmute. So if the admin can unmute him, we have a couple of questions to him too.
Actually, you cannot unmute from here. They have to unmute themselves. We can only request them.
Okay.
Nobody.
Okay. And Dr. Taru, I think he has joined a little bit late. I have a question for Dr. Tarun Chabra, if you are here now. So,
yes, sir. Yes, sir.
The cauda equina syndrome, you said a delayed discectomy. How delayed did you perform this study?
Sir, the presentation of the patients were delayed because of the various reasons, because of the poor background and availability of the spine surgeon at a rural level. So it was a study by Dr. Ujjwal Devnath in Calcutta. So whatever duration when the patient came, they opted the surgery to explaining the risks and keeping the psychology of the patient that some benefit will be there. So they counseled all the patients, whether it was 1 month, 2 months, 3 months, they included in the study. So it was beyond 72 hours, like urgent decompression was done in, has to be done in 48 to 72 hours. So all the patients were after 72 hours.
Okay, it was after 72 hours, no prefixed.
Yes, sir. And we have found out that improvement was there, grade 5 MRC in 5 patients, and SD scores also improved, sexual dysfunction scores improved, also blood and ball, they improved, but that was the most common factor for dissatisfaction after the surgery.
Okay.
Arun, can I ask one question to Tarun?
The last
yes,
one.
Sir.
Yeah, Tarun, what scores did you use for sexual dysfunction?
Sir, sexual dysfunction USP scores were done, and for male and female, separate score was there for the female, sir. Sexual dysfunction scores for the female and males both were different.
Okay, thank you, Tarun. Anyhow, you are looking like a rock star.
Keep thank you, Guru, sir. Thank you.
Dr.
Thank you,
Thomas is ready to answer the question, sir. Dr. Thomas.
Thomas.
Sorry, Ashish. Yeah, I'm back.
I just wanted to ask, like, of your 58 patients, means if you didn't have an option of nerve root block, how many of them you would have operated?
So I think the natural history of, we know that the natural history of lumbar disc herniation is favorable. And I think 80% of people will get better with or without injection.
No, that's true.
I think the advantage of the injection is that if you give it early in the course of the disease, if you give the injection early in the course of the disease, it will reduce the duration of pain and disability. So we've shown that within 30 minutes, there is a 80% drop in the pain. So I don't think it changes the ultimate natural history, but I think it reduces the duration of pain and suffering. And hence, we advocate that it be given early on in the course of the disease, rather than wait for medicines and physio not to work and then use injections later on.
Sir, can I ask one question, sir?
I think the time is up. Sorry, Dr. Tarun. I think the time is really short here. So I think we'll go on to the next 5 papers, and if time permits, you can again come back to the discussion at the end. Okay?
Yeah. So next paper is by Sudeep, who is going to present on percutaneous iliosacral screw fixation for sacral fractures and SI disruption. Whether the choice of matters or not, choice of position. Yes, Sudeep.
Good afternoon, everyone. My paper is on percutaneous iliosacral screw fixations in supine or prone positions, when to choose what. Unstable pelvic ring fractures, usually type B and C and tennis zone 2 sacral fractures, have got a more complex clinical scenarios where the percutaneous screw fixations are found to be more effective in clinical and biomechanical stability, which can be done either in the prone or the supine positions. We did a retrospective study of 138 patients, which were enrolled from 2016 to 2018, especially for the type B and the type C pelvic fractures and the type 2 sacral tennis fractures. 131 patients were followed up till 2 years with this, and both were radiological and functional outcome were assessed using the MAGI score at the end of 2 years. All the patients were divided into 4 groups based on the position and the anterior surgical requirement, and 4 important factors were taken into considerations. Coming to the techniques in the lateral view, using the lateral view of the C-arm, the entry point was made just below the ICD, which was confirmed in the inlet and the outlet view, followed by a 6.5 mm fully threaded or partially threaded screw was chosen. Similarly, in the prone position, we use the inlet and the outlet view and to confirm the positions, and the 6.5 mm screw was chosen. And these were results where 60 patients were operated in the supine and the 71 patients were operated in the prone positions. And this was our flow chart at the end of the 2 years follow-up, where we could make out the average operation time was more in a prone position group, which required an additional anterior fixation. Similarly, the number of hospital stay was more. Similarly, the average radiation exposure was more in the supine group, which required an additional anterior plate fixation. So this was our case examples where a right SI joint disruptions with a partially threaded screw was used along with an anterior plate fixations. And this was a sacral fractures which was extending into the sacral foramina, where we use the neutralization screws. So coming to the take-home message is, screw fixation in supine position is more safe and effective in a polytrauma patients who have got an anesthetic risk, which require an additional anterior pelvic ring fixations, or patients who require visceral bladder injuries. So patients with obese isolated pelvic ring injuries which require dislocations to be reduced, we can use the position in prone positions. But however, it's got a more surgical time and a more long hospital stay. Thank you.
Thank you. Now we go on to the next presentation by Dr. Dheeraj Sonavane. This is about neglected or delayed unstable hangman fracture. Is anterior only approach sufficient?
Hello friends, I am Dr. Dheeraj Sunavne. I work as an associate professor and heading unit at Grand Government Medical College and Gokuldas Teshpal Hospital in Mumbai. So today I will be presenting a short paper on neglected or delayed presented Hangman's unstable fractures and whether anterior approach has been sufficient to manage them. So as we all know, Hangman's fracture is a fracture of C2 pars interarticularis with C2 C3 subluxation. And neglected means if they presented more than 3 weeks. So most of these patients presented with kyphosis and C2, C3 subluxation. And you can see there is a significant distraction at the fracture site. So we have operated all the patient with anterior tricortical iliac crest graft after a discectomy. And with the help of skull traction, we have reduced the kyphosis as well as translation. And anterior cervical plate has been fixed. We have taken bicortical purchases since the odontoid is small. These are the cases. And all the patient has achieved union. There was no serious post-operative complaint, even with a high cervical approach in all the cases. So in conclusion, we will say that anterior cervical plating with autologous iliac crest bone grafting for neglected Hangman's is a safe and effective and reliable management technique. And significant correction of anterior translation and angulation can be achieved with plate reduction, skull traction, even in neglected cases. Thank you.
Thank you, Dr. Dheeraj. So we move on to the next paper presentation by Dr. Ravi Verma. This is about comparison of cemented and non-cemented pedicle screw instrumentation in the management of vertebral insufficiency fractures.
Good afternoon, everyone. My study is regarding comparison of cemented and uncemented pedicle screw instrumentation in the management of vertebral insufficiency fractures under the guidance of Dr. Mahesh, Upendra, Raghavendra, myself, Dr. Ravi Verma. Pedicle screws being rigid fixation, in osteoporosis they have less fixation. Hence, cement augmentation increases the pull-out strength of the screws. Retrospective study where 45 patients were included. Cement augmentation was done in 16 people and non-cemented in 27 people. Few parameters were studied. Few examples of uncemented screws where there had a distal screw breakout with increased angulation with an adjacent fracture. Patient was advised surgery but didn't undergo. Another example of uncemented where distal screw backward was noted with an increase in distal screw angle where cement augmentation had to be done because of increased pain and unable to walk with a good follow-up result. Another example of proximal screw displacement can be noted. Few complications seen in cemented group where proximal screw was displaced without any complaints. Another complication, adjacent fracture was noted in cemented group after a trauma. So coming to the results, though kyphosis correction was better in non-cemented group, fixation was better in cemented group because there was less decrease in kyphosis correction and less change in proximal and distal screw displacement angle. There are 3 patients went for resurgery in non-cemented group with a pull-out rate of 33%. Only 1 patient went for resurgery in cemented group with a pull-out rate of 11%. There was no cement leak or pulmonary embolism noted in the cement group. Few studies showed similar results with a better mechanical strength in cemented group. Also, our study is consistent with other biomechanical and cadaveric studies showing pedicle screw instrumentation a better alternative. Conclusion, cement augmentation provide rigid fixation and better mechanical stability. Cemented screws are a better option in elderly fractures, decreasing their morbidity post-surgery. It is effective, clinical, safe and easy means to reinforce pedicle screws in osteoporotic spine. Thank you.
Thank you, Dr. We move on to the next presentation by Dr. Singh. This is about single stage reduction and stabilization of subaxial cervical facetal dislocations by posterior only approach using pedicle screws.
Good afternoon, myself Dr. Ramlan Singh. I am going to present single stage reduction and stabilization of subaxial cervical spine dislocation by posterior only approach using pedicle screws. Coming on to AMM objective. Aim of our study to analyze clinical and radiological results of the patient with subaxial cervical spine dislocations treated with posterior only approach using pedicle screw instrumentation. Coming to literature, according to Michael et al., patients with subaxial spine subluxation treated with anterior only approach shows postoperatively 13% post-op loss of reduction. This is one of our patients with C5, C6 bifascial dislocation, operative posterior only approach. This is the 15 months follow-up X-ray, and patient neurology improved from D to A. This is another example, and this is another example with the intra-clinical pictures. Coming on to material methods, we have a retrospective study, and patients with bifascial or unifascial dislocation are included in the study, and all patients are operated with cervical pedicle screw instrumentation. Radiological outcome are measured compared to the degree of translation and segmental lordosis. Coming to results, we have total 34 patients and average age is 46 years, and most common mode of injury is road tripping accident. Coming to radiological outcome, anterior translation has reduced from 38% to 1%, and sagittal alignment has restored from 12 degree kyphosis to 2 degree lordosis. Coming on to neurological outcome, one patient has improved from ASIA C to E, and 4 patients have improved from ASIA D to E. No patient show the worsening of the neurology. Coming on to conclusion, advantage of this posterior only approach is superior biomechanical strength, lesser operative time, lesser blood loss, and shorter segment of instrumentation, a lesser chance of traction injury to the nerve cord, and this cervical pedicle instrumentation giving 3-column construction so that stability will be more. Thank you.
Thank you very much. So the last speaker of this session, and it is Dr. Bineet Oza. This is about a comparative study of functional outcome between posterior lumbar fusion and posterior lumbar interbody fusion in spondylolisthesis.
Hello everyone. My topic is a comparative study of functional outcome between the posterior lumbar fusion and the posterior lumbar interbody fusion in spondylolisthesis. So the emerging question is, do more adult patients affected by ischemic spondylolisthesis have significant clinical and radiological improvement following the posterior lumbar interbody fusion than those who receive the posterior lateral fusion? So my sample consists of 20 patients, 10 in each group. Mean age was 54.3 years. Complaints were back pain, radiculopathy, and numbness. Most common level was L4, L5. Most common grade was grade 2. Preoperatively, we checked for neurological examination, which showed motor deficit in 3 patients, sensory deficit in 5, SLR less than 60 in 12. Postoperatively and in follow-up period, we looked for relief in symptoms, and neurological and functional assessment was done using the Japanese Orthopaedic Association score, the VAS score, and the Frankel scale. Here is a case which was operated with a posterior lumbar fusion at L4, L5, S1 level, and the movement of spine was found to be normal in the follow-up period. This is another case which was operated with posterior lumbar interbody fusion at L4 and L5 level with a bullet cage, and the movement of spine was found to be normal in the follow-up period. So my results showed that an average operating time in PLF was less than the PLIF group, and the VAS score at 6 months showed that the pain was comparatively less in the PLF group, while the JO score stated that the functional improvement was better in the PLIF group, but the difference between the both was not that significant. A case of dural injury was noted in one PLIF group, and persistent symptoms were seen one in each group. So to answer the question is no. PLIF is a more invasive technique with more operative time and more complications, but both techniques have satisfactory functional outcome. Thus, both posterior lumbar fusion and posterior lumbar interbody fusion are equally effective for spondylolisthesis. Thank you.
So I would like to ask Amlan Singh, as you have said that in posterior approach, it is less blood loss, less morbidity, more speed. I fail to understand because anterior is always less morbid, faster, and even blood loss is less.
Yes, sir.
Because you are doing posterior dissection, how you can say that it has less blood loss as compared to anterior, where you hardly get any blood loss?
But actually, sir, in case of ASIA patients with ASIA, post-op area management will be better with the posterior approach, sir.
That because you can say only when you compare, no? Because the paper which you quoted, that was long back. Now you have a better anterior plates. So like in my personal experience, and I think there is a documented series also, where anterior is good enough and it is so fast. Means majority of times you don't need to go posterior. Majority of times. So of course anterior will be faster, less morbidity, and less blood loss. Okay. Now, next question to Mr. Sudeep. It's like you do a iliosacral fixation, and whichever cases are with anterior segment fracture, do you address the anterior injury first or iliosacral fixation?
Yes, sir. In the patients which have got both the anterior and the posterior, we usually look for, most of the times, if there is a diastasis of more than 4 centimeters. Along with that, when the patient has got any iliac dislocation, that is, to say SI joint dislocations. In those conditions, if the patients have got both, we first fix anterior, that is, we reduce the pubic diastasis. Then we see whether the at the same time the SI joint is reduced or not. Then we move on to prone positions, because most of the times, if this joint is not reduced, we may need to reduce it by percutaneous and do the SI joint screw fixations. But we did not compare, like most of the anterior plate fixation is there. It doesn't mean that most of the time the SI joints gets reduced or not. Most of the patients, it may reduce, it may not reduce, but when you have bilateral, it will not reduce. But once you have a unilateral, if there is a vertical migration, most of the times if you reduce anteriorly, subsequently the posterior reduction will be more easier.
Yes. So have you faced any case where you were not able to reduce the posterior segment in a closed manner?
Yeah, sir. We had 2 cases actually, which was not mentioned in this one, but we usually, most of the times, we use a percutaneous method. We jack it out just below the posterior superiliac spine. But most of the times, these dislocations are so mobile because you do most of the times in the acute situations. So once you jack it up and make sure it doesn't reduce in the mostly in the inlet view. Inlet view is the one where we can reconfirm whether it has reduced or not. In those conditions, we may need to open it for about 2 centimeters incisions, then reduce the fracture, reduce the dislocation, then go for an SI joint screw fixation.
Especially in vertical displacement cases, I've seen that it is sometimes it becomes very difficult to get it down. And another question to Mr. Dheeraj. Why didn't you use cage? Any specific reason?
Sorry, I haven't used any cages. I use a tricortical iliac crest graft.
No, any specific reason for not using cage?
Okay. So I don't know. Initially, I used to prefer. These were done almost 5 to 7 years back, and subsequently I have got 8 cases at that time, and now I am not getting any. So this was the time when I used to prefer tricortical iliac crest graft.
Okay, good.
So how delayed are we talking about in your cases? Delayed
so the maximum delays is up to 12 weeks.
Okay.
And there was a question from the delegate. What approach you are using?
So it's a high cervical approach. It's a transverse incision just 2 fingers below the angle of mandible. It's a similar approach to what we do for anterior cervical. Just a more vascular and neural plane has to be dissected. And the submandibular gland has to be retracted up on the upper side.
Okay. The next one is to Dr. Ravi Verma. Is he here? Yes. So, how much cement have you used in each screw, and how many levels, if you fix, do you divide the amount of cement?
Nothing like that. We have not decided.
So how much cement you use in each screw?
We use 1 to 2 ml, sir.
Okay. No, Ravi, what we wanted to ask is actually I typed that question. How do you basically do your cement augmentation? Do you use fenestrated screws, or do you put cement and then put the screws?
No, sir. We use we use that kyphoplasty technique where we introduce using a bone filling device some amount of cement and then use screws. We have not used the fenestrated variety.
Okay, and then at each level, do you use the full the cement filler device, complete cement, or do you use half filled, or how is that? How do you decide how much cement?
Less, sir.
Very less.
Very less. We have not specified any criteria, though we are using very minimal amount of cement.
Okay. Any other questions from the panelists or previous speakers? Thomas, sir, I think there are a couple of questions to you.
Sure.
What is the type of?
Before you ask me, Ashish was asking some questions about that nurses. The nurses one, that's also my paper. And fortunately, my fellow has ignored my name. So yeah. So Ashish, what were you asking about that nurse survey? Sorry.
So now I know why
some internet problems.
Now I know why nurses has been chosen as a subject.
Ashish, you're at the right track.
So now you know where.
Okay, Thomas. On serious note, Miss, you said that sadness and anxiety is means basically SNRB is not very effective, right?
No. So the nurses one, SNRB, SNRB also we found that the patients who scored higher on the DAS-21 scale did not do as well with nerve root blocks.
So you said that most of them were converted to surgery, right?
The ones who did not do well with the SNRB and continued to have pain eventually underwent surgery.
No, I just wanted to know whether this sadness and anxiety patients, they had good results with surgery too, or they were still the same?
They had good results with surgery.
Okay.
Yeah.
So that is our benefit.
But we did not compare them with the others who were not with the happy ones. We didn't compare the outcomes of surgery, sorry. But no, we didn't have any issues with them post-surgery.
Okay.
And your protocol with selective nerve root blocks before selecting a patient for surgery, what is your protocol, sir? Only a single injection or you repeat the injection back again?
So what I do is once the patient comes in, if patient comes in before 6 weeks and come to me for the first time, I get an MRI scan done if they have features of lumbar radiculopathy. And if the MRI scan shows a disc herniation and the pain in the leg corresponds to that disc on the side and the dermatome, I offer them an injection in the first visit.
Okay, Thomas, like if some patient is having grade 3 or 4 deficit, motor deficit,
yes,
you still go for a SNRB or you?
No. All these patients are the ones without deficits.
No. Means like if some patient
would I do it?
If patient is not willing for surgery.
Well, see, the SNRB predominantly reduces pain.
Okay.
We know that some of the motor deficits do get better.
Okay.
Isn't it?
No.
We know that some motor deficits do.
It won't be your first choice, but in view of motor deficit and patient refusing for surgery, would you like to do it or it is contraindicated? That's what I wanted to know.
I don't normally give them injections if they've got significant neurological deficits. I don't normally give them injections.
That's all. Yeah.
I strongly advise them to have surgery.
Okay.
Sorry, were you asking some questions about the nurses survey also? Sorry, Ashish, I missed some questions in the way.
No.
So the thing is, you are asking whether nurses have got a higher risk of back pain. There is adequate literature to show that nurses are in the high-risk group for back pain, predominantly because of the work they do, shifting patients, bending forwards and moving patients and things like that. So they, in the overall, groups of patients with the back pain, they are in the high-risk category, number one. The other thing that we found was, the prevalence of back pain is increasing and it's become a pandemic, isn't it? It's like this huge number. Back pain. Why is that happening? Clearly, it is not that there's been some, the pathologies in the spine are increasing. That cannot be.
Sadness and
over the years. See, number one, the pathologies are very unlikely to be increasing. Number two, workplace ergonomics, workplace safety, all those things have improved. There's more mechanization at work. There's less, really hard labor that people have to do compared to 20 to 30 years ago. But irrespective of that, the prevalence of back pain has gone up enormously, especially in the West.
No, but physical activity has gone down.
So the question is, what could be the
less physical activity?
But workplace causing back pain? I don't know. This is my gut feeling, and that's why we did the study. Was we felt that I think there's something like mood and sadness and depression, which is pushing a lot of chronic back pains.
No, I agree
I'm not
with
talking about acute
Ashish on
fractures,
this
I'm
point
about-
also, that our physical activity and lifestyle also has changed, and that might be one of the reasons.
No,
See,
but,
basically what I feel.
Dr. Aital, for nurses, they're working 8 hours a day. So
I agree.
They're working long hours every day, at least 6 days a week. So,
sir,
we're looking at that homogeneous population does nearly the same kind of work.
But I think the type of work each nurse does is different to different nurses. A floor nurse, physical activity is not compared to that of the
So we
scrub
did
nurse.
compare that. We looked at OT nurses versus ICU nurses versus OPD nurses versus ward nurses. There was no significant difference in the prevalence of neck and back pain based on their location of work in the hospital.
Okay, that's definitely an interesting point, I guess, because the physical activity does not come into question now.
Does it? It doesn't.
But as you said, automation has probably decreased the stress on back, but at the same time, it has decreased the physical activity too. So maybe we are less fit. So it is somewhere in between, like automation and physical activity, which is
probably.
Okay, if the time's up, I think the organizers can join back, go to the next session, or we'll have a discussion continuing on. It's up to the organizers.
We will end. So I thank Dr. Arun Kumar and Ashish Jaiswal for moderating this session, and I also thank all the participants. Nice papers. So with that, I think myself and Dr. Neeraj.
Yes, sir, we can end the session, but I would request everyone to stay here. After 2 minutes, Dr. Gautam and Dr. Chabla will be coming in this hall.
So at 4 p.m.
No, before that only. They are just finishing there in hall B. They will be coming now in hall A in another 2-3 minutes. So I request you all to please stay here.
So there will be a valedictory function.
Valedictory function, and followed by that will be learn from the master. It is the most exciting session in which we have video from Professor Dan Ryu, Professor Larry Lenke. So it's very exciting session. Next session is very exciting, sir. So I request all of you to please stay here only.
So Neeraj, that is at 4:10?
Sir, 4:10, sir. Just 5 to 10 minutes valedictory. That's what I have been told.
Oh, you finish the valedictory and then you start the
yes, sir.
Master session, is it?
Sir, that session is at 4:10. That learn from the masters is from 4:10. Right now it's 4. So within 2-3 minutes, it will start, sir.
Yeah, Gaurav has come to close the curtains. Gautam?
Gautam sir has already come.
Yeah, Gautam is all set with a neatly placed tie and ready for the valedictory. Gautam?
Good afternoon, everybody. As we come to the... Am I audible?
Yeah, very good. Very well.
As we come to the last session of the day, and this is a session which I'm sure everybody is looking forward to. Having masters showing their techniques of surgery is something all of us are looking forward to. But as we come to this end of this day, it is a pleasant duty that we have to perform. A duty at the end of each conference where we have to thank the people who have participated in this meeting, the people who have contributed to making this meeting a great success. And we have our president, Dr. H.S. Chabra, who will propose a vote of thanks.
Gautam, let's start with you.
Right, sir. So I, on behalf of the Association of Spinal Surgeons of India, on behalf of the president, Dr. Chabra, my dear friend and colleague, Ajoy Shetty, myself and the executive committee of ASSI, I thank each and every delegate who has watched us on any platform across the world, whether it be the platform which we have conducted or whether it is the OrthoTV platform or our YouTube channel, which is also directing. I thank you for making this show a grand success. For any show to be a grand success, the academics in it have to be fantastic. And for the academics, it is the faculty who takes the credit. We had 35 foreign faculty who got up at all hours of day and night to be here, share their knowledge and experiences with us. I thank each and every one of these foreign faculties. Besides the foreign faculties, we had senior Indian surgeons from all corners of India, again sharing their experiences, staying with us from 7:30 in the morning, as Dr. Shankar mentioned, to 11:30 in the night, talking about their experiences and something from which all of us could learn. I thank all our Indian faculty. The free paper presenters, young guys doing fantastic research, so much of hard work, 100 free papers were presented, 70 posters were presented in the conference, another feather in the cap. Along with this, I would like to thank the entire executive committee. Among them, especially Dr. Neeraj Gupta, Dr. Ankur, Dr. Gururaj, Dr. Charanjit, Dr. Ranjit, Dr. Janardhan, Dr. Thomas, Dr. Rupinder, Appaji, all of them have worked extremely hard to make this conference a grand success. I would be amiss if I did not congratulate the Grover team. We've not had any audiovisual hassles from the time they've been on board, and to manage such a big conference without any hassle is amazing. Also, our event managers, our partners who have done a fantastic job in communicating with people. Thanks to our secretariat, Dr. Nima and Miss Nima and Meenakshi. And at the end, as we finish this term, I would like to again thank our president, Dr. Chabra, who has guided us, motivated us, and come up with. There was never, when I thought I had done everything, Dr. Chabra next morning, Gautam, why don't we do a spine future navigation session? And I would have to say, sir, abhi kya karna hai? And then he would start with it again and we would get it. So he kept on egging us on and made this conference, which started this much, into bigger and bigger and bigger. And we came up with a fantastic show. So I thank Dr. Sir. I think what you have done for us was not only show us that, yes, don't limit, tunnel your vision. You've shown us that once you've decided this much is done, then keep on growing bigger and bigger and make it better. Work hard. Thank you very much. And with that, I pass the mic to Dr. Chabra.
Thank you, Dr. for your kind words. I totally echo your sentiments about thanking everyone except the last one, because I believe it is the team which did most of the job. And I think, as I was mentioning before, we have created history in having the first virtual ASSICON proper. The last conference that we had in September was not an ASSICON, but that was a pilot. And I think we have demonstrated that the path which has been shown to us by our past presidents, our founder, Dr. V.T. Ingalhalikar, and subsequently the all other presidents, whether it is Dr. Rajashekharan, Dr. Ram Chadda, or all of them, I think we have been able to build up on the solid foundation laid by them. And today we can say we are a mature society. We are growing as a society, and we are a force to reckon with. I would only want to say that ultimately we are for the benefit of our patients, and let's join hands together to eliminate or bring respite to patients with spinal ailments. So I won't take much of your time. Would want to thank everyone that Gautam thank all of you. And I would only say, long live ASSI. Thank you. Jai Hind. Shankar, would you want to say a couple of words before we wind up this?
Thanks, Chabra. I think, as we just said in the hall, in the other hall, while we were doing the valedictory, I think you have created history. This present executive has created history by getting so many international faculties, as Gautam just said, 35 international faculties, and 3 days of sessions from morning 7 till evening 11, and 93 Indian faculties with some, or I think more than 1,000 registered delegates. And when you sit in a virtual conference, you're sitting glued to the chair all the time. Every session is so clear, so crisp, so nice that you don't want to miss out anything. And really, I'm thankful to you, both Chabra and Gautam, and Ajay, who has really worked very hard because of this temporary indisposition. He's not able to join with us, but he really put his mind, heart to it, along with the secretariat and all the core executive teams. You can see Ankur, Neeraj, Guru, Ranjit, Janardhan, Rupinder, all of them, and others who I have missed out, all of them there every time, including Charanjit, putting WhatsApp messages, putting messages to people, putting in the chat box. Everybody has been super active. And I think Dr. Rajashekharan, we have 3 presidents here, Dr. Rajashekharan, Ram, and Chabra. You must be really happy that you have led the foundation, and it is going as per your direction. I must thank the delegates. I must thank all the people who participated. I see another president coming, just signing in, Dr. Samajit Basu. So thank you all for the content, the clarity, the education, the material, the research, and the protocols. I think Chabra and Gautam and the whole executive have taken it a long way. And of course, I must again thank here the Grover team, because they have done an impeccable job. I have also seen them grow for the last 15, 20 years. When, if people remember, I had taken Grover to ICS 2008. That was the first time I had taken them there, and that from there they have really advanced so much well. So congratulations to them, as well as to the secretariat, who have also put in a lot of hard work. Thank you, everybody.
Over to you, Gautam.
Thank you very much, Dr. Chabra, Dr. Shankar. And we now move on to the last session of our conference. And that is, as I said, the much awaited session of master techniques in spine surgery, shared with you by the masters. And to moderate the session are also Indian masters, Dr. Rajashekharan, Dr. Ram Chadda, and Dr. V. Ravi, who will take you through the session.
Thank you, Gautam. Thank you, Chabra. So let us start this session. But first, on behalf of all my co-moderators, Ram and Ravi, I think we have to echo the thoughts that are in every delegate's mind of how well this conference has run. So a big congratulations to the entire team. And this conference has been fantastic, but as always, we keep the best for the last. And here we have 4 experts telling us how to do a procedure, how to do it correctly, how to do it without complications. And we will have 4 experts here. Arun, one of our own persons, and we have our friend Paul Taylor from Australia, Dan, who has visited us many times for cervical spine, and of course, Larry. So no arguments that this is some of the best faculties that we could get. So to start off...
May I interject for a moment?
Sure, Ram.
Raja, there is one past president among us who keeps himself in hiding, and we need to recognize because he's been a very major milestone in ASSI. Arvind Jaiswal is also here with us, and he's one man who's handheld all of us. And I think we need to put it right. Thank you so much, Arvind. You've led all of us. God bless you so much. Thank you so much.
Sorry, I didn't see Arvind, but that's why I called him Bada Saab. I mean,
I also didn't see him, sir. He is my mentor.
Apologies, sir.
Yeah, so Arvind is our Bada Saab.
Let's move on.
So for the very first, we will have the first session on total endoscopic laminophoramectomy for cervical disc herniation by Arun. Ram, you carry on from here.
Good morning, everyone. My name is Arun Bhanot, and I will be talking about the technical aspects of full endoscopic posterior cervical foraminotomy as a treatment choice for cervical radiculopathy and its video demonstration. We all know that posterior approaches started in the 20th century with the advent of microscopic laminophoraminotomy, and then they gradually evolved with the introduction in the early 21st century of this full endoscopic technique. The aim of all this evolution has been to minimize the approach-related unwanted damage to the intervening anatomical structures. Now, if we look at these 3 pictures on this slide, the upper 2 show the microscopic and the endoscopic tube foraminotomy, and the lower one shows the full endoscopic foraminotomy. All 3 are showing the same structures, that is the exiting nerve root arising from the thecal sac. Now it is quite easy to see that the best vision is provided by the picture at the bottom, that is the full endoscopic foraminotomy. The reason is the constant saline irrigation under which this surgery is performed, and it gives a very nice visual picture of the anatomical structures. The full endoscopic foraminotomy is done using a working channel endoscope that has a 4.1 millimeter working channel whose endoscope is 25 degrees, and this is done through a tiny hole in the skin which is used to introduce the 8 millimeter diameter working tube which is beveled at the distal end. The full endoscopic surgery is done under constant gravity-assisted saline irrigation. As the medium of vision in this surgery is saline, so it clearly offers certain advantages. There is hardly any bleeding, and there is no undue reddish haze in the operative field. The saline, in addition, acts as an additional dissecting tool to create separation between natural planes. All this combined provides us excellent optics of the anatomical structures as they naturally exist in the body. The full endoscopic technique is suitable to treat foraminal and paracentral disc herniations. Earlier, large herniations were considered as kind of contraindication, but nowadays even large herniations with the major component as paracentral as shown here can be treated safely with the endoscopic technique, as can be the moderate foraminal stenosis. However, central herniations and specifically calcified herniations with myelopathic features are not good candidates to use this technique. So is the presence of instability and severe axial neck pain. Now coming to the technical surgical aspects, the patient is positioned prone under general anesthesia. I prefer to use the soft headrest as shown in the picture above, but some people use the Mayfield as per their liking. After positioning, we have to mark the target on fluoroscopic images. In the AP view, the mid-facet line is marked like this, and in the lateral view, the line of direction of the disc space is marked like this. The lateral view line has to be in line with the concerned disc space. The aim is to dock the initial instruments at the lamina-facet junction as shown here on the sawbone model. Once the markings are done, they look like this on the patients. Our entry point will be just medial to the vertical line marked on the AP view. After marking, we prep and drape the patient and then use a sterile 16 gauge needle to insert on the intended track and reconfirm the trajectory under C-arm control. The needle should aim towards the base of the facet joint, again reiterating in line with the concerned disc space. I prefer to give the stab incision under C-arm control as shown here in this small video clip. The idea is to cut right through the fascia and also check for the inadvertent anterior passage of the knife. The cutting of the fascia permits easy gliding and introduction of the subsequent blunt obturator, which we have to use. Then we introduce the blunt obturator, or we call it dilator as well, to create the track. The dilator is aimed to touch the facet lamina junction, and once it touches the bone, you can check the position under C-arm, and then you can just use a slight gliding motion to clear the soft tissues above the bone. After that, we bring in the 8 mm beveled working tube and glide it over the blunt obturator, and once the position of the working tube is confirmed under C-arm, we remove the obturator and bring in the endoscope and introduce the endoscope through the tube, and then one can clear the overlying soft tissues over the lamina of the upper and lower vertebra at that level. Now, before drilling, one can again check for the level so that there is no inadvertent slippage of the cannula above or below. And once this is done, then drilling starts initially at the inferior lamina of the upper vertebra as shown here, and then it proceeds laterally towards the lamina facet junction, and from there to the upper edge of the lower lamina. This is a case example of a 35 years young male whose video we will witness just now, who suffered from severe left arm radicular pain that did not improve with IV analgesics and other conservative measures, and he had a minor neurological deficit in the form of grade 4 triceps motor power. This is the MRI showing a large paracentral C6-7 disc herniation. This is a picture that shows the clear identification of the bony landmarks before we drill. This is the C6 lamina, this is the C7 lamina, and this is the facet joint. In between is the ligamentum flavum, and this is the V that we define before we start the drilling. Now coming on to the video. So the needle is passed and check the trajectory. Then the obturator is introduced and gliding motion is done. Then the blunt obturator is the beveled working tube is introduced, and then the endoscope is brought in to remove the soft tissues covering the bone. This is the flexible bipolar used for hemostasis and shrinkage of the soft tissues. Now the bony edges are being defined. This is the orientation, the C6 lamina, C7 lamina, and the facet joint as I showed earlier. Now we start the drilling from the inferior edge of the upper lamina of C6, and then it proceeds under close endoscopic monitoring towards the facet joint, and then we drill the medial border of the facet joint. From there we move on to the upper edge of the C7 lamina here. Once we thin it out, we will start seeing the insertion of the ligamentum flavum to the undersurface of the C7 lamina, and then we can see the opening of the epidural space. We clear the ligamentum flavum with this probe, and then we bring in the endoscopic kerrison to remove the thinned out lamina, and use this endoscopic kerrison as well to take out the ligamentum flavum. One can also cut the ligamentum flavum with the endoscopic cutters, just like we do in the interlaminar endoscopy at the lumbar spine. So after clearing the parts of ligamentum flavum covering the neural structures, we start seeing the spinal cord, and then we have to look for the origin of the exiting nerve root at that level. We would like to clear the exiting nerve root right from its inferior to the superior edge bit by bit, and then we can see the disc bulge under the exiting nerve root in its axilla, and this is the C7 nerve root. So once the nerve root and the thecal sac and disc is identified, then we bring in this right angle hook probe to open up the fragmented herniation and remove all the fragments bit by bit with the endoscopic grasping forceps. Once we remove these fragments by delivering them gently, we can see a little bit of gush of blood at the end of the decompression, and then we probe the superior edge of the nerve root to look for any hidden fragments under the nerve, and as is expected, there is a small fragment which is again mobilized and taken out from the axilla. Once this is done, we can see the decompressed nerve root. It is fully decompressed along with the presence of thecal sac, and this is the postoperative MRI showing complete decompression of the neural tissue, all done through this small tiny hole. Now there are certain pitfalls that one needs to avoid, and one of the major ones that I have felt is the possibility of a wrong level surgery. That can happen if we miss the correct guide regarding the choosing of skin entry point. So as shown here, this is the correct line, but if we shift our entry point slightly inferior, even if we touch the same endpoint on the bone, there is a possibility that while clearing the soft tissues, our obturator and cannula can glide up and reach the wrong level. So it is better to stick to the in line with the disc space entry point. Then there are certain points to consider while performing this surgery safely. One should be careful about using the bipolar excessively close to the nerve root. The irrigation pressure preferably should be under gravity and not to use the pump, but if you use the pump, then avoid excessive irrigation pressure. If occasionally the bleeding obstructs the vision, one can use the blunt obturator through the working tube and hold it there for some time to cause a tamponade and hemostasis rather than fiddling blindly because you are dealing with the cervical spine here. Avoid getting too laterally because in cervical region we know too lateral is also anterior and one can endanger the vertebral artery if one is not careful. So these are the cautions that one should exercise while doing this surgery. To conclude, the disadvantages of this technique is that it is limited only to the indications of paracentral and foraminal herniations. If there is a need for intervertebral space to be reconstructed, that cannot be done. And the biggest one is that learning time. It is a long learning time, and in the hierarchy of the full endoscopic surgery, it comes at the right at the top. So one should not attempt endoscopic cervical surgery in the beginning of his or her career and gain sufficient experience before starting these procedures. The benefits of endoscopic foraminotomy: once it is learned and mastered, it's an easy and simple technique, as you just saw. There is much less trauma to the tissues. The bleeding is also not much. There is no operation-related neck pain as you hardly cut any structures. There is no need of fusion, so mobility is preserved, and there are hardly any access-related complications. And because there is no implant, there is less postoperative pain, so the postoperative cost of care is also reduced. But the biggest advantage is the excellent unmatched visualization of anatomical structures that help to do a safe and effective surgery. Thank you.
Thank you very much, Dr. Bhanot, for an excellent presentation. Any questions from the panelists here? Anybody practicing this on a regular basis and has faced any situation they would like to share?
My question is... Can I ask a question to Arun?
Yeah.
Arun, it was a nice presentation as usual. There are two questions. One is, sometimes it's difficult to identify the level at C6, 7.
Yes.
and it's a big problem because you cannot do it in without you have a C-arm guide.
True.
So that is one problem, and the other is if there is a hard disc and osteophyte which is anterior,
right?
How do you deal? This is a soft disc, but if there is a osteophyte, then how to deal with it?
So the first question first, you said the C6, 7 levels, and sometimes we have to treat C7, T1 as well.
Yeah.
So one trick is one can use the traction, skeletal traction, and that can open up that area. Well, that is one. But still, sometimes in short neck people, you can't see the C6, 7 region in the lateral view. In that situation, if someone wants to perform, then we have to learn to introduce the needle and the guide under AP view more than relying on the lateral view. That is the second option. Otherwise, without seeing, you can't do that, right?
Yeah.
Now coming to the hard osteophyte, which is lying anterior to the nerve root. Yes. If the osteophyte is lateral to the lateral edge of the thecal sac and under the nerve root, there is an instrument provided in this set, which is like an end cutting. The surface of the small tube-like instrument which goes through the endoscope, which is called as the end cutting instrument, that can be used, which will glide just under the nerve root, and then you can rotate it and it will trifine. It will act like a trifine to trim that area. So one can use that instrument to do that's why I said moderate level of stenosis can be treated. But if it's a very severe stenosis coming from the front, then it is not a good indication for the technique.
Thank you.
Any other questions?
Regarding the facet joint resection, how do you confirm that you haven't resected too much so that it shouldn't create any instability at a later date?
Right, sir. Dr. Ravi, the facet joint resection, if we know our tube foraminotomy, it is mentioned that up to 50% of facet can be resected without causing any instability. Because of lack of time, I did not show the post-operative CT scans. Actually, in this particular surgery, you cut hardly about 20% of the facet. We have measured pre-op and post-op because the scope is able to go closer. So you do not have to look from the top. Whatever you want to see, you can go closer to the nerve root. So without needing to cut too much of facet, you can perform this surgery. And I have compared, it is just about 20, maximum I have cut is 25%. I would cut more facet. I have recently cut a facet more than 25% because it was a case of associated foraminal stenosis and the disc was lying all in the foramen only. There was no paracentral disc. So in such a situation, you can. And the benefit of endoscope is that you can actually take the endoscope down into the bottom and look under the nerve root without cutting the facet.
No, my point is, how do you confirm clinically that you haven't resected too much? Is there any point? That's what I'm asking. Clinically, operatively, when you are doing the surgery, anyway, you can say that it is not too much cut.
Right. So our aim is to expose the junction of the origin of the exiting nerve root from the thecal sac and look at it for the length which we have measured in the preoperative assessment, that this is what I have to decompress. So your instruments are certain, like 4 millimeter instruments are there, 5 millimeter are there. So you can just put that probe inside and check whether you have cut that much only or not. So that will give you a intraoperative guide.
Thank you so much. Dr. Jaiswal, last question.
Yeah, quick question. Arun, great video. You were doing all this through a tube very nicely. So what made you switch to endoscopy, and is there any limitation as such compared to the tube?
Sir, if you see, the visualization is much superior than the tube because of the constant saline irrigation. So you do not see that. If you remember, we always used to talk that there is a bleeding, epidural bleeding, which is a trouble in the tube. So in this particular surgery, that bleeding component usually doesn't disturb us unless and until we happen to be a little casual about picking the epidural structures and injure something. Otherwise, the constant irrigation keeps washing the small bleeding points, and you get a good, excellent visualization.
Is there any incidents where you would prefer to use a tube rather than an endoscope?
Not these days. If the same indication is this, then I would prefer to use this.
Thank you very much, Dr. Jaiswal. A short question, short answer, last question. Dr. Bhanot, is there any indication for transuncal foraminotomy with the advent of posterior endoscopic or tubular microforaminotomy?
Yes, if there is a severe anterior osteophyte under the nerve root which cannot be accessed, that can be done transuncal foraminotomy from the front.
Thank you so much, Dr. Bhanot. Thank you very, very much. Excellent presentation. Good questions. May we now invite Dr. Paul Taylor. Dr. Taylor is going to be sharing his experience on OLIF. Could you please share your slides, sir?
Thank you to SR and Ajay for inviting me to be part of this virtual conference. It is indeed an honor, and particularly to be included in a session with such legends of spine surgery. So I've been asked to talk about anterior to psoas or OLIF surgery. First thing, a few comments on patient selection. The vast majority of patients are suitable for this approach. It's relatively few patients that the prevertebral vascular or vertebral anatomy make them unsuitable for this approach. So it's only 1 or 2 patients a year that I think are best managed with posterior-based operations. The obese patients, anterior to psoas is often a good option for them, certainly a lot easier than direct ALIF. The fat can often act as a retractor, and that actually helps you. There is some difference between those that have the saggy belly and those that have a very tense, tight, barrel-shaped belly. They're a little more difficult. Be cautious with slips greater than grade 2. There is less overlap of the vertebra, and therefore you have a greater risk of penetrating the canal or obliquity and injuring the contralateral nerve root due to that smaller area. Look for transitional anatomy. You will become more expert in understanding the vascular variation that occurs in the lumbar spine. And generally speaking, if you look at 5.1 and you think that the vascular access is easy, the vessels are wide apart, then generally that will go with a relatively steep, difficult disc angle. And for those in which you find that there's an easy disc angle, it's pointed straight ahead of you, usually that will go with a difficult or more difficult vascular access and less room between the vessels. At 4.5, such as on this one, there are occasions where it's better to go between a bifurcation, but again, that's only 1 or 2 a year. Make sure that your radiology company don't cut off the vessels in your MRIs. You need to look at them. So this is a typical Australian patient, sadly. We're often dealing with a fair level of obesity, and this is how we position them. Surgeon stands at the front. The patient is taped to the bed. And to get perfect AP and lateral x-rays, often you need to have the patient slightly head down and rotate the upper hip and shoulder a little forward. Rotate the patient and the bed, not the C-arm. Make sure that you keep the C-arm in true AP and lateral to make sure you get those perfect AP and lateral images that are better for and safer to operate on. If you are considering doing simultaneous single position posterior pedicle screws, then rotate the bed backwards around 10 degrees, still with the patient being on it vertically, because that will then and also place the patient at the back of the bed. That will then help you with that down screw coming up. So the lower screw, it'll help you. So around 10 degrees of tilt on the bed is what you will need. Incision planning, I mark the disc, I mark the crest and the superior iliac spine, and then I draw a projection in line with the disc, and then I draw my incision. So the solid red line there is the incision. Don't stay too close to the crest. Again, that's a bit of a beginner's error. You think I got to stay as posterior as I can to make sure I can get to the disc, but you will end up with more branches of the cutaneous nerves there, and so you'll end up with a few more complications and nerve pain. Incision planning, if you're doing 4-5-1, which is the typical 2-level that you might do, if there's a large divergence in disc angles, which you can see on this patient, then typically I'll either make 2 separate incisions or occasionally 1 skin incision with 2 fascial and muscle splits. But if the patient's disc angles are nearly parallel, then 1 incision and 1 split. Here you see a patient with disc angle that is pretty parallel, so it's a 1 incision. And then I'll mark the projection of the 5-1 disc. So that's the lower dotted line that you can see. And then from the midpoint of that disc, a horizontal just coming straight at you. And the typical 5-1 incision is between these lines. If, however, you're doing 4-5-1, I drift a little cranially, but not too far, because you still want to keep 5-1, which is the harder operation. You want to not make that too difficult. So I drift just a little north for that to be able to do those two. If I'm doing 3 levels, if there's no scoliosis, then I'll typically do 5-1 through one skin incision, and then 3-4 and 4-5 through a second. If it's mid-lumbar, then I'll do 3 levels through one incision, centered over the middle level. And I'll typically do the middle level discectomy first, but not implant. Then I'll go to the top, then I'll go to the bottom, and then come back to the middle and implant as the last one. If it's scoliotic or a significant kyphosis if it's scoliotic, I'll go through the side of the concavity, because the discs are pointing towards your skin incision then. The genitofemoral, lateral femoral, iliohypogastric, etc., all have a cutaneous supply. We learned at medical school that the nerves run between the internal oblique and transversus, but as they have a cutaneous supply, they come to the skin, and therefore you can find branches of those nerves at every level. So be cautious as you're doing the approach. This is a typical approach. There's the external oblique, so I'll simply split it in line with its fibers, then put a little retractor in that will show you the internal oblique coming into the lateral rectus fascia there. I'll then split that in line with its fibers, and then we look at the third layer. And this image here is designed to show you that on the left there, the fat deep looks matte, and that's with the transversalis fascia still intact. But when that fascia is opened, the fat looks glossy. Sometimes as you start, you'll think, is this transversalis or is this peritoneum? And that's one way. That's one way of trying to determine. Once you open transversalis, which I'm just doing here, trying to get back, that's the next step, and perhaps the most important step of the approach. The simple way of doing that is just 2 index fingers, just simply walking the peritoneum forward. You can see just simply the action there of 2 index fingers, just sweeping forward, sweeping forward, sweeping forward, and the peritoneum will roll up off the lateral body wall and up off psoas, and then you'll feel it in the crook of your finger, if you like. You'll feel that you stripped it forward, and you'll start to feel the striations of psoas on the tip of your finger, and then you know everything's in front of you, and you're all the way at the back. And as you see here, you'll just see there's a proper retractor in there, psoas, and there's genitofemoral just lying on it. When you start, have a look at your if you're new to the approach, have a look at your scans. Certainly if you come in on that one, as soon as you come off psoas, you're onto the vertebral body. But if psoas lies anterior, as they do in some, if you go straight ahead, then you're going to be into the vessels, so you need to go backwards once you're around the front of psoas. So just recognize that. It's not difficult to deal with, you just need to know it's there. And the other common beginner's mistake is that you're frightened about being too anterior, and so you go behind psoas and find yourself looking at quadratus. Just remember, if there's any striated muscle in front of you, you're too far back. Genitofemoral nerve lies in a little pocket sitting on the front of psoas and its fascia. Drop of local anesthetic there just as you come out will often help with pain. And the sympathetic nerves are very variable, but they're usually can be dissected anterior or posterior, and they're virtually always able to be salvaged. There's the disc, or kept rather. There's the disc, and there's the sympathetic. I use a little tool with the sharp and blunt edge to do that. As you do the discectomy, just make sure that the patient isn't drifting forward or backwards. So keep an eye on your x-rays and adjust the rotation as you need to. I perform the discectomy first to make sure that I'm not pushing nucleus into the far nerve root. Be cautious of your angles. If you're used to using a tubular approach, then that will constrain your angle of approach. Once you go to OLIF, you'll find that you have more angle of approach, and you've got more chance of therefore gouging the end plate. Ensure you release the far side of the annulus. That reduces the chance of the cage splitting back. If you break the anterior longitudinal ligament, either a plate or a pedicle screw above and below and a little rod will help, will solve that problem for you. Generally place the cage as anterior as you can, but try not to overstuff the disc. The lower end plate is weaker, and you will get the subsidence risk. lordose your disc correctly, have a look at your pre-op balance analysis, and the orthogonal maneuver. If you're using a straight inserter, it won't always get you there. I think you need to use an inserter and trials that have a dog leg or an angle on them. This is just a representation of a tubular approach. It lines you up with the disc, and therefore you can't really gouge the disc too much. But if you're using OLIF for the first time, you're coming at an angle, and so you have more chance of injuring the vertebra. If I'm doing 3 levels, then I'll take the middle disc out first and collapse it down. Then I'll go to the top disc, so I'm not pushing it away underneath the ribs by the others. So I'll do the top disc first and implant, then I'll go to the bottom and implant, and then come back to the middle. It is just a clinical example, two-level operation and 2-level cage with percutaneous screws. And here's another with a preoperative lordose of 39 degrees there, anterolateral cages, 2 incisions, and percutaneous screws only, no posterior work there, and an increase of 20-odd degrees of lordosis. So here's the typical approach. I use that dog leg device to access the disc. And you'll see that's how it implants. There's the cage in the disc space, and there's a plate over the top, and the typical blood loss and a 1-level incision. If you have bone loss, then you can use the tangent formula to work out how much plastic to drill away of your cage. At 5.1, a couple of comments. That malleable device there is the device that helps keep the ureter out of the way, and that's important when you're implanting, particularly if you use that device. And there's a typical view. You can certainly use a buttress plate for slips, as you can still then correct over the top. And now I tend to use just a screw with a washer. So which approach when? Well, I think the approach winds like a helix, and so up top it's a more direct approach behind the 12th rib, and down the bottom it's more anterolateral, and so those are the approaches that I think we should consider. There are some cases that you shouldn't do ATP on, and here's a pretty classic one. Here's the common iliac arteries, there's the external iliac veins, there's the internal, there's a dilated ureter, there's the psoas, and so your access window is pretty small, and I wouldn't choose to do that in this, or in this aberrant left common iliac vein there. That's a difficult one to do. But soon, with some practice, you can end up with cases that look like so. There's plenty of evidence for the anterolateral approach, and perhaps I'll leave that slide up there as we go to some questions. Thank you very much for listening.
Paul, that was excellent. So thank you very much for this great video, and thank you for your time on a Sunday. I'm sure that there are a lot of questions because this procedure is something that's getting more and popular amongst the members of ASSI. And so I will throw the floor for questions now. Yeah. Paul, I will start it off. If you have a large number of osteophytes and some amount of translation, what you see in this degenerative scoliosis, do you have any particular difficulty? Do you need to chop away these osteophytes before you start?
No, not really. Often you don't need to take the osteophyte. Osteophytes often do produce more lateral stability, of course. So in the curves that are the biggest, they tend to be the patients that don't have many osteophytes because they haven't thrown out those lateral stabilizers. There are times, of course, where there is a rotatory listhesis. That's more of a challenge than the osteophytes, where there's a substantial rotation at the level, and then it's a matter of making sure that you recognize the step, and that you don't gouge the disc as you go through. Don't gouge the end plate. I'm sorry. So I have several shims, so they start at 4 millimeters. So there's pretty much, if there's a vacuum phenomenon on the CT, then you can put a cage in it almost always. So if you can still see some gas on the CT, even if it's very, very collapsed, just starting with some very small shims, you can sequentially dilate up the disc. But a lot of the companies only start with 8-10 millimeter shims, and they're just too big for a lot of these degenerate spines.
Yeah, there are two more questions from the audience. So Ranjit has asked, what is your policy? Do you always release the ALL, or is it selective?
No, I rarely release the ALL. I perform an ALL release deliberately for an anterior column reconstructional realignment operation where I'm then putting in a very specific cage, which is a hyperlordotic cage, 25-30 degrees. And those cages I then fix themselves. They have a little tab on them that I fix to the vertebra itself. So no, the routine does not divide the ALL. When you want to start deliberately dividing the ALL, that is a more complicated operation. You have to pass a retractor between the spine and both aorta and IVC, and so that's not for your first 50 or so, I would say. My comment in the talk about ALL is occasionally you will find that you curetted the ALL and it will break as you dilate up the disc space, and that was just a comment on how to manage that intraoperative problem.
Yeah. So the last question, a quick one. What is the salvage if you damage the end plate in an osteoporotic spine?
Yeah, so well, there's a couple of things. Firstly, putting a cage wide enough so that you are bridging the ring apophysis, so you're not hanging your cage in the soft central bone. That's number one. Number two, you don't overstuff the disc. If you know you've got a weak, if you've gouged or you've got a problem, don't go for broken. Put in a super big cage. Number three, you can place if you're going to, in that circumstance, I would definitely place pedicle screws as opposed to a plate. And in my inferior pedicle screw, I would angle them up to sit just underneath that cage, so that if the cage subsides, it will sit on them. The other element that you can also then do is cement the vertebrae. You can do a vertebroplasty of the vertebra underneath, and that's done commonly in China.
Yeah. So Paul, thank you. It was absolutely a very fantastic video and very well explained. And thank you very much on behalf of all of us.
You're very kind. Thank you very much for including me and asking me to be part of your fabulous meeting. Thank you very much.
So I'd like to invite, good morning to you. So thank you for joining us on the Sunday morning. And can I request you to present your video on the cervical osteotomy for kyphosis? Thank you, Dan.
I'm Larry Lemke. Now we'll be describing posterior vertebral column resection for complex spinal deformities.
I think there is a problem
highlighting this technique.
I think you're
showing exposures.
Please play Dr. Daniel Hughes' video. This is Lawrence Linke sir's video. Please play the other one.
Video. This is the next one. We just now said there was no hitch in the audio video for the last 3 days. You should never tell that.
Which one, Punesh, sir?
This is by Dan Ryu. Ankut, can you coordinate?
Yes, sir.
Dr. Ryu always just wanted to do VCRs. That's why. Deep down inside.
Hi, Larry.
Good morning, Raj.
He just didn't want you to jump in front of Dan.
I guess not. I would never do that.
Yeah. Dan, do you have your video with you? I mean, we can just go on. Okay, it's
Thank you very much. I'm going to be talking to you this morning about anterior and posterior osteotomies of the cervical spine. These are my disclosures. I do get some royalties on the Biomet Maxan anterior cervical plate. This is a case of a patient with ankylosing spondylitis and psoriatic arthropathy, and she has a fixed kyphoscoliosis of the cervical spine. You can see on the CT scan that there is abundant bone both in the posterior as well as in the anterior spine. And the three-dimensional reconstructed CT show that there's a confluence of bone in the front as well as in the back, and she has a chin-on-chest deformity. This is her on the operating table, and you have to keep her head suspended by putting enough sheets or pillows underneath the shoulders so that the head is suspended, because during the procedure, we're going to be sequentially pushing her head down. And at the end of that anterior osteotomy, the head's going to be touching the bed. In order to support this, after you position the patient, you're going to put some sheets under the head, and you're going to ask the anesthesiologist to sequentially take out one sheet at a time as you perform the osteotomy. The first thing you have to do is you have to find the uncinate, and I place a Penfield 4 on either side of the uncinate, because a lot of times when this is solidly fused, you don't know where the old disc space used to be. So by palpating lateral to the uncinate and putting one on each side, you can tell that you're going to be cutting right in between the two goalposts. So this is a video. It's an 11-minute video, so we're going to have to fast forward it through so that we can get it in this talk. And so we cut through initially with a burr, and then place a Penfield 4 lateral to the uncinate. That tells me how far lateral I have to go and protects the vertebral artery. And I just keep burring and using curettes and so on until I get closer and closer to that Penfield 4. So let's go ahead and fast forward a little bit. We're about 1 minute and 40 now, at 2 minutes into the osteotomy. We keep getting closer and closer, and you have to do this carefully enough that you're not going to injure the vertebral artery. So the first thing you do is you go posteriorly until you hit either the the posterior longitudinal ligament or the scar if it's a iatrogenic deformity that you're correcting and they've had surgery before. And you keep going laterally with that burr. And when it's pretty well thinned out, you can use curettes, you can use an osteotome. You can even take the Penfield 4 and go from lateral to medial and just crack it out. So here I'm just using a burr, and I'm palpating laterally and seeing how far out we are. I placed a little patty lateral to the uncinate, so that's also helping to protect injury to the vertebral artery. So now we're at about 4.5 minutes, close to 5 minutes. And we're going to take a small curette and use that to go lateral to medial and break the posterior aspect of the uncinate. And now it's actually come apart, but we're going to remove all the rest of the small amounts of bone from within the foramen so that we don't get foraminal compression, which actually you don't in most cases, because you're going to open up that anterior foramen as you extend the neck. And so this usually doesn't cause any foraminal compression. After finishing the right side, I'm standing on the patient's left, by the way. The head is to the right of your screen and the foot is to the left of your screen. And then we go to the contralateral side. And again, we place a little patty between, you can see the patties right about here. And I'm putting a curette in there, and I'm going to crack it from lateral to medial. This is osteoporotic bone, as most patients who have an ankylosed spine will, by Wolff's Law, resorb it, and it'll become soft. Now I put a curette to protect the artery, and I'm just going to get close to the curette, the sucker, and get close to that and remove the bone. We'll kind of fast forward this. Now we're about 8 minutes into the osteotomy. There we're in, I'm going to take you can see the curette just kind of feeling for where we're at. And that's a Penfield 4. Just going lateral and seeing where we're at, and then I'm going to put a sucker there in place of the pen field. That pen field is kind of just dissecting the artery and pushing it kind of laterally. And once we've achieved that dissection, I put the sucker in and then take the burr. And we're about 9 minutes into now the osteotomy. And you can see it's not a lot of bleeding. If you do get bleeding, you just put some of the hemostatic agents in and get hemostasis. You can put some bone wax in also because you're going to be burring through it anyway. And now I've taken the last lateral margin of the uncinate, and I've used a little curette to remove the last little flexibone from lateral to medial. There we go. Now that's pretty much all broken through, and the uncinate is now opened up, and now we'll be able to distract across that space. You can see it's now mobile, and you can see now it's quite mobile. So in the interest of time, we'll go past that. So this is what it looks like intraoperatively, where I put a sizer in, mallet it in, and then I put sequentially larger and larger ones to dilate out the disc space. And this is what it looks like intraoperatively on the left and a light camera on the right. So we remove all the bones. We take a 5 millimeter sizer, put it in, and kind of jimmy it back and forth. While on the right side, you can see I'm pushing down on the forehead through the drapes. This is the patient's head under here, and I'm going to push down on the forehead as I'm simultaneously levering on this sizer and sequentially putting in bigger and bigger sizers. And you can see under the microscope what's going on. And then we can go ahead and put in, and this is another view of the same thing, but this time you're just paying attention to what's going on inside of the spine, where I'm putting a 5 millimeter sizer and jimmying it back and forth. And then we're going to put in a 6 millimeter sizer, and then a 7 millimeter sizer, then 8, then 9, and you can see gradually increasing that space so that that's the osteotomy. And simultaneously, remember, I'm pushing down on the head, and that's the force that is being generated. Meanwhile, the anesthesiologists are taking out one sheet at a time, so the head is constantly resting on something, but we're constantly pushing it back so that at the end of the procedure, anteriorly, the head is now touching the bed, and you've got a correction. So this is what it looks like after the anterior part is done. And we do osteotomies at 3, 4, 4, 5, 5, 6, 6, 7. This is actually, it looks like a corpectomy, but it's actually the 6, 7 disc space that we really distracted and opened up to get a correction. The root is well decompressed. The spinal cord doesn't undergo much stretch because we're actually shortening it, because it used to be draped over this kyphotic area. And now when you push it back, it's no longer draped over it. After the anterior osteotomy, you can see the head is now touching the bed. All the sheets that used to be under there have been pulled out. And then we go posteriorly. We do a meticulous dissection midline and a muscle sparing approach. And then we use osteotomes here to do an osteotomy through the facet joints. Often this is already broken after the anterior. It actually ends up often cracking open on its own. But in case it hasn't, we use an osteotome on one side and we use an osteotome on the other side. And there's usually bone that joins one lamina to the next. And so we take a high-speed burr and remove all the bone overlying the ligamentum flavum there. And then I use a rod compressor to kind of squeeze the spinous processes together, and also use a spinous process cable. I've used a double arm cable here and put 2 of them, and I squeeze it down once and twice, and until the spinous processes are brought together to create lordosis. It works much better than just using compression across the rods. So this is what it looks like after the anterior, after the screws and osteotomy is done, and after we put in the rods and compress and lordose the spine further. Pre-op before incision, and post-op after the anterior and posterior And you can see that we got a nice correction, not just at one level as you would with a PSO. We got a gentle correction at each level, providing a correction. So it's a much more natural restoration of the cervical curve. You can see the lumbar spine is no longer hyperextended in order to look straight ahead. She's got a much more natural posture in the AP as well as the sagittal view. And we published this a number of years ago with a Smith-Peterson osteotomy. It would take us 3 hours and 50 minutes on average with 230 cc's of blood loss. A pedicle subtraction osteotomy took almost 6 hours and 700 cc's of blood loss. An anterior and a Smith-Peterson, which is what I just showed you, took 5 hours and 21 minutes and had 325, less than half of this. And the time was less than a pedicle subtraction osteotomy at a single level in the cervical spine. And so this is a much more natural way to correct the deformity, and you can do it at any level in the cervical spine, whereas if you're doing a pedicle subtraction osteotomy, you typically want to do it at below C7 so that you don't have to worry about the vertebral arteries. And it's hard to get a one level to correct enough coronally and sagittally without impinging on the C8 nerve root. Whereas if you do it this way at multiple levels, what you're doing is you're creating a gentle correction at every single level that you do the osteotomy. And the same thing, if you have a curve in the coronal plane, you can gradually shift multiple levels to get the kind of correction that you want. So thank you very much for your attention, and thank you for allowing me to speak today.
And thank you very much. Great as usual. That's just a fundamental question. So in your anterior approach, you had created the osteotomy and then you have fused the segment, but I just also. So when you do the posterior surgery, where is the correction occurring? So Dan, you are muted. Yeah, okay.
Can you hear me now?
Yeah, wonderful. Very well. Yeah.
Okay. So what I was saying is that when you do this osteotomy from the front, what often happens is that the facets will actually break in the back exactly where you've done the osteotomy in the front. And if it doesn't break, what's happening is that the fused spine, you're plastically deforming it. And then when you go in the back and you just take a little osteotome and just chip through the facet joints as you're doing a Smith-Peterson osteotomy, what you'll find is that because there's such tremendous force from the anterior correction, just a little tap with an osteotome and cutting through the interlaminar space that's been fused with a burr will allow it to gradually go back to the position it's supposed to be in. So it's actually a very gentle way to do the osteotomy.
Yeah. And in your posterior fixation, where would you typically take your lower instrumented levels?
So it depends on where the apex of the deformity is. I typically want to get at least a few screws below the lowest level that we're doing the osteotomy on. And so this one, we did osteotomies at 3, 4, 4, 5, 5, 6, 6, 7. And then we went down to T2. And so we will usually plate the very bottom level so that if we go in the back, we don't have to go down too far. So if you plate the bottom level, you can just go get by in most individuals with the pedicle screws into the last level also, because now you've got 4 screws below the construct and you got screws in the front and you got screws in the back. This one, we actually did a C7T1 ACDF also. So we basically backed her up in the front and the back, and so she had a very rigid and stable construct.
Raja, you are muted, Raja.
So when you're dealing with these osteoporotic bones and when we are using the spaces to open up, if there is a damage to these end plates do you use a tricortical graft instead of a cage?
So most of the force is coming from pushing on the forehead through the drape. So rather than just the spacer. So you put the spacer in a small size that fits without doing that, and then you push it back and then you lever it back and forth, and that just sort of allows you to work without having to damage the end plate. But even if the end plates are damaged, it's kind of crushed, and it makes the bones a little bit stronger because you're crushing kind of the end plate and it's getting more compact, the bone is. And I've taken to using just cages because it's faster. Otherwise, I have to take a fibula and I got to cut it, size it perfectly to the size that I want. I got to put it in. And the goal is to get the anterior done in about 2.5 hours, no matter how many levels you do, because if you go beyond 3 hours, then I recommend that you keep the patient intubated. And most of these patients we do, and the patients typically in the United States can go home within about 48 to 72 hours. And so if you take too long a time doing the anterior, you got to keep them intubated, you got to keep them in an ICU, and the complication rates go dramatically up. So the goal is to get in, get your thing done, and get out. So I found that the fastest way to do that is to just say, give me an 8mm or a 10mm cage, and only when I'm really distracting, like I did in this case at C7, will I take a fibula, cut it, and put it in.
That's good. Last one. Pushing the head down, how do you control your force? I mean, have you ever had a crack?
No, because the head is supported by a whole bunch of sheets in the back. So the anesthesiologist, I asked them to take one out, and then the head is only about maybe 3 or 4 centimeters off of the blankets you have left. And so you're only pushing down by about that much. And then you have them take out another couple of blankets, and then you push down again. So it's a very gentle, controlled force. And you can, just taking out one sheet or blanket at a time, it really allows you to get a gentle push on the forehead without something going crack and going all the way down, because obviously that would be catastrophic.
Oh, yeah. Wonderful. So thank you very much, Dan. That was really good. Thank you very much for the Sunday morning time. Say hello to Mary on behalf of all of us. And now over to Larry. Larry, good morning to you also. And,
good morning. Morning. Glad to be here.
Can you just show us your video on vertebral column resection?
I'm Larry Lemke. Now we'll be describing posterior vertebral column resection for complex spinal deformities with a video highlighting this technique. Here are my disclosures. All deformity surgeons are aware of the powerful correction to be obtained with the posterior vertebral column resection technique. As you know, we remove apical vertebra or vertebrae, thereby separating the spine into 2 sections that can be rejoined, shortened, to take off the tension on the spinal cord, and then rejoined to correct even the most severe spinal deformities. I feel comfortable speaking and highlighting a video on this technique, as I've done over 300 of these cases for severe spinal deformity and have many publications highlighting not only the technique, but how to make this surgery as safe as possible. Here's a case to be highlighted. This is a teenager with neurofibromatosis. He has an angular kyphoscoliosis as seen on his upright AP and lateral x-rays. Both the coronal and sagittal deformity angular ratios are quite high, connoting the angular nature of the deformity. This is nicely seen on the 3D imaging pre-op, especially from the more anterior perspective that's circled in yellow. In addition, we evaluate the spinal cord with this new spinal cord shape classification system. Type 1, the spinal cord is outlined by CSF at the apex. Type 2, the spinal cord touches either the pedicle, vertebral body, or laminar bone at the apex. And type 3, the spinal cord tissue is actually deformed by the bone at the apex. Not surprisingly, this patient has a type 3 spinal cord shape at the apex due to his severe angular nature. So here's a video of this case, and we'll start out with orientation. To the left is cephalad, to the right is caudad. To the top of the screen is the right side of the patient, to the bottom is the left side of the patient. And I'm standing on the left side of the patient as the operating surgeon, so the view you'll be seeing is my view, basically, through this procedure. And we'll start out here, again, having the screws already placed above and below the apex. We're putting the left-sided convex temporary rod in. You see the amount of bend in the rod corresponding to the severe convex deformity, concave kyphosis deformity. And as you'll see on these type of severe angular deformities, I prefer to have bilateral temporary rods on both the convexity and the concavity of the deformity. Obviously, no screws at the apex of the bodies that are going to be resected. So we have secure periapical temporary fixation obtained on both sides of the spine. Obviously, needless to say, we have to have very secure pedicle screw fixation above and below the apex on these kind of cases as well. So here we're now dissecting out and removing 3 of the concave apical ribs that will be used for bone graft as well. You see we have the lamina still intact, spinous process. We've not done our laminectomy yet for safety purposes. Here we are dissecting the lateral edge of the rib from the pleural surface with a Penfield 1 elevator. And you'll see remove the remaining portion of the rib with a Kerrison rongeur to, again, carefully remove the bone, saving the bone for later fusion purposes. Also trying to avoid any pleural defect as well during the removal of the rib head here against the lateral vertebral body wall. All right, so now we're going to basically start our laminectomy. Again, we do a very generous laminectomy, including all spinous process lamina of the vertebra to be resected to the inferior aspect of the pedicles above to the superior aspect of the pedicles below the resection vertebra. We save obviously all the bone. That's why I prefer to use a rongeur as much as possible to save as much bone as possible for the dissection. Better on the convexity of the lamina. You see here. Another thing to note is that there will always be a lot of venous engorgement of the epidural veins on the convexity inside the spinal canal, since the concavity, again, is contracted by the actual dural surface, which is sitting preferentially in the concave region of the spinal canal. So the convexity is where those epidural veins tend to be located. So we have to control those to minimize our bleeding, and obviously during the entire surgery we're optimizing our field of view and also minimizing blood loss at all portions of the surgery. So now we have the convex hemilamina, spinous process removed. Now we're going to remove the concave posterior bone. You see it's much more cortical, so we're going to burr and thin it down initially first here. And obviously the concavity of both the spinous process lamina and pedicles are much more cortical than the convexity, so we're thinning this down very carefully with careful dural protection at all times here. A high-speed burr, then we're going deeper and closer to the origin of the pedicle. We'll get a close-up view of this in a second. And so we carefully thin down all the bone on the concave portion of the deformity here. We try and save the concave nerve roots. They're heading, on this patient, kind of straight towards the floor, so we save all the concave nerve roots. Here we are taking a Kerrison rongeur and carefully removing the most lateral bone here, again off the dural surface. Careful dural protection at all times. And saving this bone again for fusion later in the procedure. So also, now we're going to compress at the convex apex to shorten the spine. So we intermittently do this to take tension off the concave spinal cord by compressing the convexity as we continue to remove bone going from posterior to anterior. shortened by a few millimeters. We do this intermittently throughout the entire procedure. Now we're separating again the medial dural surface and spinal cord from the concave pedicles to be resected. And we're going to use again a high-speed burr very carefully here. You'll see a close-up view of this in a second to highlight how we carefully protect. You see the dural surface there with the high-speed burr. Obviously the pedicle here is very tiny and completely cortical, so we have to carefully just drill that down into the base of the vertebral body again, trying to save the nerve root sitting both above and below the pedicle, since again in the concavity everything is so contracted. So here we're now going through the pedicle into the base of the vertebral body, one of the concave pedicle levels. Careful dural protection at all times. It's nice and slow and safe from this perspective. See the nerve root right there? That's exiting. So now we're carefully getting the Woodson elevator just underneath the most concave portion of the dura. It's very, very tight here because of the severe angular nature of the deformity. So now we're going through the pedicle into the base of the concave vertebral body. Further remove that with a burr. Again, it's impossible to remove that with a curette because of the cortical nature of the bone at that region of the spine. Again, more convex shortening compression here of the convexity to shorten the spine and take some of the tension off the spinal cord as you remove more of the bone off the concavity. And that's the concave portion of the dissection. Next we'll move to the convex portion of the dissection. So here again we have the nerve root on the convexity ligated. When nerve root ligated, we're using a curette to remove bone and disc from the convex portion of the body. You see we're working around the temporary rod and the convexity here, so we leave that in place. So we remove both bone and disc, and obviously we save the bone for later fusion. Use a combination of curettes and rongeurs. Now here a high-speed burr for the most concave and deep portion of the bone. We kind of paint away the ventral and the most medial portion of the vertebral body. Now we also separate the ventral dural sac and spinal cord from the dorsal bone of the vertebral body as well as the disc material. We kind of push that into the defect created with the corpectomy. Here we're using a Woodson elevator. You can use a reverse angle curette, or there's a special posterior wall impactor that does this as well. Again, completely ventral to the dural sac, removing all that bone. Make sure everything is nice and free so it won't be impinged as we continue to close down the defect even more. So everything's nice and free here circumferentially. You see the Woodson elevator pointing it out. Now we're continue then to close the defect even more aggressively here now that the VCR is being completed circumferentially. So it becomes much easier to compress now because of the resection. When we're fully compressed to the level we want to be, now we add a third rod as a central hook rod construct to basically hold the correction in place over the apex. As we've removed our temporary rod on the left side and place our permanent left-sided rod, we do the convex permanent rod first to be able to cantilever the apex more ventral for more additional correction of the kyphoscoliosis. Here we are again, placing the rod all the way to the distal portion of the instrumentation and fusion. Further closing of the defect is done. All the way up to the top of the construct. Now we're going to fill our anterior defect with a cage. So we template for the cage here, ventral to the spinal cord against the end plates that have been compressed together, both above and below. The cage is tapped in position, usually filled with autogenous bone, and then we further compress on the cage to lock everything in position. The final correction here, I'm compressing both cephalad and caudad to the cage at the vertebrae adjacent to the VCR site. And constant palpation of the dural sac with all these maneuvers to make sure everything's free, ventrally, dorsally, laterally, on both sides. Obviously, we'll be following our spinal cord monitoring data as well. So here, before we finish, we do place bivalved ribs over the laminar defect for both dural covering and also a hopeful osseous fusion crossing laminar defect. You see the morselized bone placed the bone below as well for fusion, and the 3 rods that are in position for support of the BCR site until healing. Here are the final AP and lateral x-rays following this T1 to L3 instrumentation and fusion with a 2-level BCR with very nice coronal and sagittal plane radiographic correction noted. And here's the pre and post-op clinical photos of this patient who did quite well with no perioperative complications. And I thank you for your attention.
Larry, thank you very much. That was an excellent demonstration. So Larry, you said you have done more than 340 of these procedures. So over the period of time, what have you changed in the last 40 or 50 surgeries? What have you modified upon yourself that has made it more safer?
Sure. It's been over 20 years, basically. So I started doing these around 2000. I did some circumferential VCRs as I was taught by Dr. Bradford, Dr. Kostowick during my training. But by 2000, after I had visited Professor Suk in Korea, I switched to the all posterior procedure, and I have not gone back to do an anterior posterior because, again, as you know, in severe deformity, the anterior part of the spine is located posteriorly in the body, so there's no reason to go to the side because it's actually closer to the posterior skin than it is the lateral part of the body. So what I've changed, interesting, the last 5-6 years is I'm doing slightly less number of VCRs, even though I can tell you my practice complexity is about the same. And so what I'm doing to occasionally not do a VCR in cases that are kind of on the borderline, or maybe doing apical pedalectomies to let the spinal cord drift over into the cavity and maybe not remove the entire body, right? Just the lamina pedicle, especially if the pedicle is holding the cord tight, as I showed you that spinal cord classification system. I really look carefully at the pre-op MRI to see exactly where the cord impingement is. And if it's more dorsal or more dorsal medial, I maybe do a laminectomy and pedalectomy and let the spinal cord drift over to allow tension off the cord before correction. Some kyphoscoliotics that maybe are not as angular at this, I'll do a lot of posterior convex compression, just continue to squeeze posteriorly on the convexity, and sometimes the spinal cord data will stay intact, and I'll get very nice correction without, again, doing a VCR. So I think the most number of VCRs I did in 1 year was around almost 40, and now I average around 15 to 20 per year. So I'm doing about half the number of VCRs. Again, for I can tell you a similar complexity of practice, but I'm just finding ways to avoid this if I can. I mean, obviously, the more angular the patient, the patients with pre-op myelopathy almost always get a VCR. But again, I don't think there's some cases that are a bit borderline. They can be managed with multiple posterior osteotomies and careful correction, again, without tensioning the spinal cord. That's the key. If the cord's under tension, the apex has to be shortened, and that's when the VCR is often best. Or again, a pedalectomy to allow the spinal cord to drift over. You got to take the tension off the cord, right? That's the key.
Yeah. So, Larry, we are all worried about the neurological deficit.
Right.
And many times in our country, and it must be for you also, the patient comes with a partial neurological deficit.
Right.
And they have severe myelopathy, and even pre-op, the monitoring doesn't do such a wonderful job. So how do you take it up? We are always a bit worried when the monitoring doesn't work pre-op.
Yeah, right, exactly.
And then,
so the two main the differentiator on that is, if you don't have good monitoring, do you have enough of a motor exam to do intraoperative wake-up tests to follow? And sometimes you do have enough function in your feet, sometimes you don't. You know, if someone really is not going to be able to get a good wake-up test in the OR, then basically I talk to the patient and family and say, this is what the patient needs. Without surgery, the neurologic function is going to continue to deteriorate, so we're going to do the best, safest job we can. Although we are kind of flying blind, we cannot follow the data. We have to be very careful, but this is really with the best surgery. If there's enough function to follow wake-up tests, then I'll do serial wake-up tests. during the surgery to see exactly, and I'll do them at multiple points in time, even after I position the patient. Sometimes just by positioning alone, as you know, in these very severe angular deformities, you can have a little more extension to the thoracic spine and lose some of your function. Just so get an idea exactly where you're at. But again, if the patient is so involved neurologically, at the end of the day, you really have to take the bone off the cord. So you have to do that operation. It's just trying to make it as safe as possible. So you know exactly where you are in various stages. And, you know, you have to also, you know, you can't rush. You can't go so quick that you inadvertently hit the dural sac, hit the cord. You got to be very careful because that's a very sick cord, right? So there's no reason to rush. Because even if they wake up with a bit of a deficit still, which about a third of my patients do, I've actually studied this. A third of the patients from myelopathy wake up normal, a third wake up about the same, a third wake up worse, including some that wake up paraplegic. But if you've done a good, careful job decompressing the cord and not over shortening too much, they will get better. Inadvertently, almost all of them. So that's how I counsel patients about that very difficult situation.
Yeah. Also, a few years before, I think probably some years before, you used to talk a lot about staging these complex deformities. But now I don't hear that from you. So have you, has it been a shift in your plans or on staging? What are your current staging?
Yeah, I think that, you know, that's a matter, I think, of I think personal experience, you know, how efficiently you can do these surgeries. You know, I don't like to be in surgery more than 8, 10, 11 hours. I think nothing starts good happening after that. You know, patients that are, sometimes patient factor, sometimes patients are just too unhealthy, you know, to have 10, 12 hours of surgery, including closure. So I still don't mind staging them. Raja, I really instruct my fellows to consider doing that when they're first getting in practice, unless they're doing a very short, you know, 4 or 5 level, you know, BCR. But certainly those that I do, you know, upper thoracic to sacrum ilium, you know, you do inner bodies down below, you're doing a total spine reconstruction, including a multi-level VCR. I'm still staging those, honestly. I think it's best for the patient. I've actually published on that. There is no difference in complication rates doing single or 2-stage, at least in my hands, surgery for complex VCRs. Interestingly, in that paper, even though there was no difference in complications, if you drill down the data, the patients who had 2-stage surgery actually did a little better. To tell you the truth. And even though they were the most complex patients, because the reason I staged them was the surgery was more complex, but actually is absolute numbers wise, they had less complications. So do not hesitate to stage these for either patient or surgeon reasons. That's exactly what I preach.
All right, good. Arvind, you wanted to ask something?
Yeah. Oh, great presentation, Larry, as always. And a couple of technical questions, if I may ask you. Number one is that how do you size your cage and when do you insert your cage? Number one. Number two, what are your tips when you're going to do the concave osteotomy? Because majority of many a time, you know, that's where your MEPs just go for temporarily. So these two questions are there.
Right. So for the cage sizing, as you saw, I think a little bit on the video, you know, I try and get 90% of the correction done before I put the cage in, because I've tried, when I put the cage in earlier, then I do more correction, and the cage often gets loose or just doesn't fit right. So I really wait to the very end to put my cage in when I'm 95% corrected. Then you see, I just use spacers. I use, you know, pre-fashioned titanium cages. You can certainly use bone if you want, but I prefer cages. It's just, as Dr. Wu mentioned, at the end of the day, it's just easier to take a cage that is the right height, width, and length and just put it in, you know, for sizing than to cut a piece of bone. But that's certainly fine. It's your choice. But what I don't recommend is putting bone on bone, because when I've done that, I've had a couple of pseudoarthrosis. I think bone on bone is too slippery. So the cage, you know, interdigitates with the end plates and provides a little shear resistance. So even if I can get bone on bone, I open it up and put a little cage in, honestly. That's unscientific. I don't have enough data to prove that that's better. But honestly, that's what I do. I never put bone on bone. Very rarely, never say never in spine surgery. I very rarely put bone on bone. I almost always put a cage in if I can. As far as the concave osteotomy, you're correct. As I mentioned, the tension's always on the concavity, right? And that's why I really study the pre-op MRI, see exactly where the spinal cord is sitting relative to the body, the pedicle, and the lamina. You know, depending on how much sagittal plane pathology you have at the apex, it's, you know, if the lordoscoliosis, it's going to be sitting more against the lamina, right? Kyphoscoliosis obviously sitting against the body. So it depends. So that's why kyphoscoliosis, to really decompress the cord, you have to take the body out, right? It's very hard in a true kyphoscoliosis or a kyphosis to leave the body because the cord is resting there, right? But a lordoscoliosis, you can certainly drill off the lamina carefully and the pedicle, and the cord will drift out of the way, and then take the tension off, and you don't have to do a complete body removal, a complete BCR. That's what I mentioned, and that's what I'm doing now more and more, honestly. So I'm kind of studying where the spinal cord, and studying pre-op, but also confirming intra-op just by palpation, obviously, and how the spinal cord is reacting to the bone and lamina removal and pedicle removal, and also that you have to pay attention to the data, right? The spinal cord data really helps drive your decision intra-op as well, as far as how much bone to remove, where to remove it, how much to shorten. Shortening is very helpful, as to take tension off the cord. So I'm constantly shortening the spine on the convexity if there's a convexity. So all these factors are kind of constantly interplaying during the surgery to make it as safe as possible.
Sometimes the cord is hugging the pedicle, and pedicle is absolutely narrow most of the time on the medial side, right? Do you recommend that you go into the disc space, and if it is hugging too much preoperatively, also in the MRI, leave a portion of the pedicle? Because the pedicles are very, very small, and you'll be able to open up at the disc space. Maybe is that safer technique? Do you always do that? A type of an asymmetric sort of thing, get into the disc space, and then your convex opening.
Sure, right. Yeah, sure. Honestly, I certainly have done that. Kind of a modified, almost PSO instead of a true VCR. You're right. Yeah, I mean, the key is the tension has to be off the cord, because that's where we get in trouble, as in these deformities, as we start correcting, because there's always a tendency to lengthen the spine as we're correcting deformity, right? So, and if the apex is really sharply angulated, that's where we get in trouble by having spinal cord monitoring changes. So whatever it takes to decompress the apical cord, that what you mentioned works very well, especially again, you're right, on some severe deformities, the apical pedicle is non-existent. It's a little thread of cells, right? It's hardly any bone. Exactly. So no, you can absolutely do what you want, but just make sure whatever's sitting ventral to that is not going to impinge on the cord. And as you know, it's harder to take away disc than bone. So sometimes the disc is very hard to take away, right? So if it's not impinging, I leave the disc. You're right, because it's very difficult to take that away.
So why did you say that you did not remove sacrifice the concave nerve root?
Yeah.
That sort of anchors it, isn't it? Why do you
I just found I don't need to. I honestly, I used to do it 15, 20 years ago, but over time I realized I just leave those there. They're nice. They're thick nerve roots, and they're usually heading straight towards the ground, and they don't really get in my way. And so, again, probably 90% of the time I'm able to save them. Certainly 10% of the time, either I inadvertently, we either burr them or they're so close together that it's impossible to take the pedicle out without ligating them. But the convex ones are important to ligate, because then the cord will drift over more. So it's important to ligate the convex ones for sure. But concave, I think it's really your decision. I don't think it's, I've done it both ways. It doesn't seem to matter. Whatever's easier.
Thanks.
Larry, what is the role of pre-op halo? I mean, do you use them? I mean, we never used them, but then Boachi came to our place, and then we became converts. We now use them routinely, and we find that it gives a lot of flexibility. So in these very difficult curves, do you use a pre-op halo?
Yes, I still use halo traction. Interesting, quick story. Professor Boachi wasn't really doing much traction, and he came to visit me about 20 years ago or so. And I had, at the time, I think 8 patients in traction at my Shriners Hospital. And I took him around to show the patients. And then he went back to New York before he went to Ghana even, and got enamored by traction. As you know, traction works wonderfully. I love halo traction. But the only time I don't use it, if this patient comes in with a completely fused instrumented spine with a severe residual deformity, but it's already fused, I normally don't put that patient in traction, because that's not going to help very much. But anyone who is not fused or has medical compromise, has pulmonary compromise from their deformity, and even sometimes the myelopathic patients, Rajesh, they can be improved slightly. If you do slow, gradual traction, you can actually improve their neurologic function pre-op. I've had that happen before I do surgery to make it maybe a little safer. So I still do a fair degree of halo traction on my patients, and I suggest you consider that, as it sounds like you guys do.
So what are your endpoints of stopping the traction and getting on to surgery, Larry? I'm sorry, this is dragging a bit. If you have time,
I have time. No, it's fine. again, it's really individualized. I think the shortest time in traction is a week or two. The longest, I had a patient in 9 months of traction once, and really was to make them healthy enough to operate on them. They came in so debilitated with so much restrictive lung disease that I think it was 11% predicted lung disease. So to try and avoid tracheostomy before surgery and stuff, I put the patient in traction for 9 months back in St. Louis. So the average is probably 3 to 4 weeks now, honestly, of traction. Because, it's not just traction for the skeleton, it's traction for pulmonary improvement, nutritional improvement, getting to know the patient, obviously, and hopefully neurologic improvement if they have a little bit of myelopathy. Sometimes with gradual traction and taking some of the kink off the cord, you can improve that a bit. So it's multifactorial why we do traction, and the average is probably 4 to 6 weeks. But again, a little longer if it means the surgery will be safer. I don't mind that, and the patients don't mind it either. Once they're in traction, the patients enjoy it. They don't complain about traction once they're used to it.
They have such a good feeling of well-being once they are on a couple of days.
Exactly.
Basu?
So, Larry, as you've always told us that pure kyphosis is much difficult surgery and much more unpredictable and much more dangerous than a scoliosis, even if it's a hairpin loop. So what are the tips of VCR in a kyphosis? Which side do you put the cage? Do you do a bilateral nerve root resection? And do you make sure that the entire bone anterior to the cord is gone?
Right. Yeah, so the only reason kyphosis is more dangerous, and that's true for any kyphosis, is that probably there's more compromise of the anterior spinal artery, right, in a pure kyphosis. So it's a blood supply issue more than a motor tract issue. So the anterior spinal artery is probably more compromised, and obviously the hallmark of that is really the congenital kyphotics, which are some of the highest neurologic risk, probably because of the aberrant nature of the anterior spinal artery is what we think. We don't know for sure, but along with the congenital bony anomalies. But no, for a pure kyphosis VCR, the key is, as I showed on the video, definitely temporary rods on both sides of the spine, not just one side, because if it sags at all, you're gonna have issues. If you already have an angular deformity, you start doing your laminectomy and you don't have strong tension band of posterior rods, temporary rods, you're gonna have even more tension on the anterior dura and more likely to lose your spinal cord data, which has even happened to me with 2 rods. And I've had great fixation with 2 rods, and you start a careful laminectomy and you lose data. Because again, there's just slight loss of tension band in the back, which puts more tension on the anterior cord and probably loss of blood supply. So you have to be very careful with those patients. Normally it is a bilateral approach, obviously bilateral pedicle excision, bilateral little rib excision. I don't take as much ribs out as I used to. So that video is probably 10 years old. So I tend to take maybe less ribs out just to try and minimize the pulmonary insult from the surgery. But for kyphosis, I will take little rib heads off on both sides. In equal work, my fellow will do, the one side, I'll do the other side, and we kind of meet in the middle. As you mentioned, all the bone absolutely has to be off, bone and disc from the ventral part of the dura and cord. And again, as you slowly compress, obviously you want to make sure it doesn't spring up and pinch the cord even further. But once you're completely free, the key is to work from the ends. Don't go at the very apex initially when you start going ventral, because that'll be so tight. So I kind of work in the less tight areas eventually first, push that off, and then carefully work to the center. And as you shorten, so you don't go right at the center itself, because sometimes you can hardly get a Woodson elevator underneath it. It's so tight. It's like it's like a tight guitar string, right? It's incredible how tight the dural sac can get at the apex of some of these angular deformities. So you work periapical first to get the bone off the dura, then you work towards the apex after you shorten a bit to take some tension off.
Larry, there is, is there a preference for you for nursing these patients in the post-op? There are some reports saying that it's better to keep them laterally placed rather than supine. Do you have a preference on that?
I've not seen a difference, honestly. I usually put them supine. Actually, we do log roll them, obviously, partially log roll to the one side or the other every 2 hours. The key is maintaining their mean arterial pressure. That's the key. You have to maintain a mean pressure. I like to have at least 80. If surgery's gone smooth with no neurologic issues or data changes, then I'll ask for a mean pressure of 80 or so for the first 24 hours. If there's any data changes at all, or obviously any neurologic issues, then I ask for a mean pressure minimum of 90 for 24 hours. And to show how sensitive the spinal cord is, I have a case report pending publication where I had a patient, older patient with a kyphoscoliotic with post-polio syndrome, who lost data from basically hypotension in the ICU post-op day 1, 7, and 15. On post-op day 15, he became paraplegic acutely, dropping his mean pressure below 75. So he stayed in the ICU for 30 days on on pressors to keep his means above 80. Because whenever we drop his means, he would go paraplegic temporarily. So the spinal cord, as you know, is very, very sensitive to blood supply. So we have to maintain optimal mean arterial pressure of these patients intraoperatively and early post-op, and sometimes even longer, as that case kind of highlighted.
Thank you, Larry. I mean, as you can see, we always enjoy your talk so much and look forward to it. And the best of the dinner comes during the dessert time. And that's why this Meet the Masters with you, Dan, Paul, and Arun. I mean, this was the last session, and you can see also from our YouTube channel, every one of our members are watching it. And thank you for giving a grand close for this 3-day conference. So Dan,
my honor.
Larry, Dan, Paul, and Arun, thank you all very much. And on behalf of everybody, we would like to thank, on behalf of Ram and Ravi, I would like to thank the organizers, our president, Secretary Ajay, Gautam, who really took over wonderfully well, and the entire team. Thank you very much. Thank you.
You're welcome.
Bye-bye.
My pleasure. Thanks, guys. Congratulations. Great meeting.
Dr. Ram Chadda. Thank you, Dr. Ravi, for moderating this session so well. And as you see, when you're operating, if a master surgeon is operating, you always feel that, oh, this is so easy, I can do it myself. And that's the feeling I got when I saw Larry and Dan and Arun and Paul doing these surgeries. Oh, these are easy surgeries. Maybe I should be starting doing them tomorrow. So this was the feeling we got. Masters at work. Sir, you kept 4 past presidents of our society and 2 future past presidents of our society waiting over here because they could not leave the excitement and the learning and the knowledge that they gained from this experience. Thank you very much, all of you. And with that, I bring this conference to a close. Thanks to everybody who has contributed to this program. Good night. And see you at 6:30 for the social program.
Thank you. Thank you, Gautam. Thank you, everybody.
Thank you. Thank you.
रंजीत भाई कितना सीखोगे?
Hi Guru, all good.
I
think we are still online, Guru.
Yeah. क्या हो गया?
Yes, thank you.
Yeah, thank you, Ranjit.
Bye. Thanks. Room sir, thank you.
I think you can leave. Deepak?
Yes, sir.
Are we offline?
Yes, sir.
Hello, Aitala sir.
Oh, so we are done. Nice work.
Yeah, we have done. Yeah.
So party starts at 6:30.
Yes, sir.
Hopefully next ASSA meeting will be offline. We can meet all of
yes,
all of you in person and
Yes, sir. Long time, no meeting.
Yeah, our ICS was the last physical meeting.
Yes. Okay, sir. I'll also leave and see you at 6:30.
Yeah. 6:30 we will join. Yes, thank you.
Days of my life. Got my first shield 16, but I find when I'm played it till my fingers bled. Was the summer of 69. Me and some guy